Hello guys, welcome to our channel. Today we are going to discuss about the Sureshot series for the upcoming FMG examination as part of our admission to 100 plus. So this is continued as three parts. So don't forget to watch and cover all the important topics. Okay, so let's start our session today. The Sureshot topic series 1. So let's start with the most important topics, guys. Epithelium. So when I discuss about the epithelium, there are the different types of the epithelium where they are lining is most important. So simple squamous epithelium which will be present in the lung alveoli and also heart lining. Okay. Next, simple cuboidal epithelium present in the terminal bronchioles along with the renal tubule. Simple columnar epithelium, this is present in the uterine tube, uterus and the intestine, because these simple columnar epithelium which will be containing of the cilia. So okay, the ciliated structures like fallopian tubes, uterus and intestines will be presented. Next, pseudo-stratified columnar epithelium, which will be presented this multiple layers, but it is actually a single layer. Here you can see, right? The structure may look like multiple layer, but it is only single layer, and it is present in the trachea, upper respiratory tract. Next, stratified squamous epithelium, which will be subdivided as a keratinized, non-keratinized. But if you have to remember the example, the keratinized is the skin, non-keratinized is the cornea, and also vagina. These are the some of the examples. Next, stratified cuboidal epithelium. In the stratified cuboidal epithelium, most important is the mammary glands. Next, stratified columnar epithelium, male urethra and glandular ducts. Transitional epithelia, which will be presented urothelium of the bladder, ureter and urethra. So these are the examples of the epithelium which can be asked in the examination. Next, in the last year examination, they also asked about the cartilages. So here how these cartilages under the microscopy look like. So first see the hyaline cartilage, where this hyaline cartilage is going to present, guys, especially in the fetal skeletal tissue and epiphyseal plates, costal cartilage, larynx, trachea and bronchi. So why this hyaline cartilage important? Because it will resist the compression and provide the cushioning and smooth friction to the surrounding joints. Okay, so that is the first thing, and also structural support to the respiratory system. So again, hyaline cartilage which will be present in the fetal skeletal tissue, epiphyseal plate, costal cartilages and also larynx, trachea and bronchi. Next, elastic cartilage. This is how under the microscopy elastic cartilage will be looking like. Next, it is present in the pinna, right? Pinna, which will be just elastic tissue only. And next, external acoustic meatus and auditory tube larynx will be presented. Next, it will provide the flexible support to surrounding and the soft tissues. Next, fibrocartilage. Mostly, this is present in the intervertebral disc, symphysis pubis, sternoclavicular joint, temporomandibular joint, and meniscus, wrist, and insertion of tendons. So this will be resisting the deformation under the stress. Okay, at least these important points that you have to remember. Next, moving on to the joints. So joints is subdivided into the how many types? So the joints is divided into the fibrous, okay, and also cartilaginous, and also we have the different types of the synovial. First, let's see the what are the fibrous. So first fibrous example, why these are known as a fibrous joint? Because fibrous joints are immovable joints. So the examples are sutures. Here you can see the suture line between the skull structures. This is one of the fibrous joint. Next, syndesmosis. This is the joint between the two important bones. For example, tibiofibular joint and radioulnar joint. Okay, so the tibiofibular and also radioulnar is one of the examples. Again, there is a no movement between this, that is known as a syndesmosis. Next, gomphosis, which will be here you can see the root of the tooth which will be consisting of the gomphosis, and it will help to stick the tooth into that particular root or the socket, that is known as a gomphosis and immovable joint. Next, another type is the cartilaginous. So cartilaginous joints are slightly movable, and the examples for the cartilaginous, here you can see these both are belong to the cartilaginous. Okay, and the example synchondrosis and the symphysis. and synchondrosis, which will be united by the hyaline cartilage. Example, just now we discussed epiphyseal plate and also sternomandibular joint. Okay, sternoclavicular joint, which will be attached between these joints, right? And these are the some of the examples for the cartilaginous synchondrosis. Next, cartilaginous symphysis. Here, the pubic symphysis, one of the joint, and intervertebral disc. Okay, these are the other two examples by the symphysis. Next, moving on to the synovial joints. So in the synovial joint, you have to remember these examples, guys. So first, whenever you see these joints, like first ball and socket joint, these ball and socket joint present in which structures? Especially in the shoulder also. Okay, this is present in the shoulder joint. Next, incus and stapes. Okay, it is present in the incus and stapes. Next, moving on to the condyloid joint. Condyloid joint is present between the radius and carpal. So this is present in the metacarpal joints. Okay, this is present in the metacarpal phalangeal joints. It is going to be presented, and also it is present in the knee joint and temporomandibular joint, which will be condyloid examples will be seen. Next, plane joints, which will be present in the tarsal bones. Okay, what are the examples, guys? Interpharyngeal carpal joints and also interpharyngeal tarsal joints. Okay, these are carpal and this is tarsal, one of the examples for the plane joints. Next, saddle joint. This saddle joint is present between the trapezium of the carpal bone and the first metacarpal. Along with that, this is also present in the sternoclavicular. Okay, this is also present in the sternoclavicular joint. Next, hinge joint, which will be present in the elbow, one of the example. Next, pivot joint, which will be present between the C1 to C2, which is also known as a atlantoaxial joint. Atlantoaxial joint. So these are the some of the examples that you have to remember, guys. Okay, next, moving on to the dermatomes. So in the dermatomes, you have to remember first the most important points in the dermatomes that you have to remember here are: what is the dermatome that will be present with the umbilicus? So here you can see here the T10 is known for the umbilicus. Okay, T10 is for the umbilicals. Next, anus. Okay, for the anus it is S5. Okay, next here you can see the big toe. Okay, the big toe, which will be consisting of the L5. Okay, and next, coming to the hand, the thumb will be supplied by the C6. Next, coming to the here, the region of the leg will be again asked in the examination, guys. So which we see anterior side, the big toe is the L5. And what about in the posterior aspect? So this is on the anterior aspect. Okay, and on the posterior aspect, what it is going to be supplied by the dermatome of L4. Okay, this is also asked, can be asked in the examination. Okay, next, coming to the hand only, the radial side. Okay, radial side, which will be C7 and C6. Next, on the ulnar side it will be C8. Okay, remember these points for the dermatomes, and not just those, every dermatome is important, guys. Just you have to remember, when you suddenly bend, that is how your vertebral column is going to supply for this dermatomes. Next, moving on to the nerve pulses. This nerve pulses topic is very important here. This topic is brachial plexus, but you don't have to remember each and every brachial plexus. At least remember this point: what are the nerve roots that is present? First, axillary nerve root. What is the axillary nerve root? C5 and C6. Same like that, you also have the other nerve, that is suprascapular, which will be also consisting of the C5 to C6, right? Next, you also have the ulnar nerve. Ulnar nerve will be supplied by the C7, C8 and T1. Next, musculocutaneous nerve. Okay, musculocutaneous nerve. Musculocutaneous nerve will be consisting of C5, C6 and C7. Next, long thoracic nerve. Okay, long thoracic nerve. Long thoracic nerve also consisting of C5, C6 and C7. Next, coming to the radial and median nerves. So radial and median nerves, which will be consisting of all five, guys. So C5, C6, C7, C8 and T1. Okay, all will be present in the radial and the medial nerves. Okay, this point is also important in the examination, can be asked. Next, moving on to the what are the types of the defects that you have to remember. Next, what is the Erb's palsy root that is involved? Usually C5 and C6. Okay, this is going to be involved the upper trunk. Next, this is Klumpke's palsy, C8 and T1. Lower trunk is going to be involved here. Sorry guys. Next, what are the nerves that is involved due to the Erb's palsy? Usually axillary, musculocutaneous and also suprascapular. In the Klumpke's palsy, this is C8 and T1, right? And this patient will be presented as a complete claw hand will be seen in this patient. Along with that, it is also going to involve the cervical chain. So if it is involve the cervical chain, that patient will be associated with the Horner syndrome. Okay, this is also important point, right? Next, how this patient, Erb's palsy patient will be presented, guys? How like waiter tip, okay, waiter tip or the policeman tip, the patient will be presented. So the defect can be described as the hand is going to be adducted position and it is medial rotation, and also patient will be in the pronated hand. Okay, elbow is extended. This is the defect. Okay, Horner syndrome. Horner syndrome, what is the symptoms, guys? Maple. What is mean by the maple? Meiosis, anhidrosis, and also the patient will be having the ptosis, okay, loss of ciliary reflex and enophthalmos. Okay, these are the findings that you have to see. Next, here this is seen in the ape thumb deformity. In which nerve palsy you are going to see the ape thumb deformity? In the patients of the median nerve palsy. And what is the most common cause for this patient? This ape thumb deformity, supracondylar fracture. Okay, supracondylar fracture seen in children. Next, this is partial claw hand. Okay, partial claw hand. Partial claw hand is seen in which palsy, guys? Ulnar nerve palsy. Next, here you can see this is the wrist drop. Wrist drop is seen in the patients of the radial nerve palsy. Next, here it is foot drop. And foot drop is seen in the patients of the common peroneal nerve damage. Okay, and foot drop can be also seen in the patients of the leprosy due to involvement of the nerve, and most commonly associated with the fracture of fibula. Okay, next, another picture here. This is the what is the nerve palsy that you are seeing here? So this is known as a hypoglossal nerve palsy. Okay, hypoglossal nerve palsy this patient is having. And what is the defect that is presented here, guys? Usually the tongue will be supplied by the hypoglossal nerve except the palatoglossal. Palatoglossal will be supplied by the other nerve. Remaining all will be supplied by the patients with the hypoglossal only. So this side is affected. So the lesion will be presented on this side. Okay, but this is the normal side. So why the patient is deviating towards the normal side? Because the nerves that is present here, that is pulling the other side of the muscle. So that's why the patient deviation is seen towards the normal side. Next, another picture here. What is this condition, guys? This is the most common seen fracture overall. Okay, most common seen fracture overall. And how this fracture? This is clavicular fracture and clavicular fracture junction. Can anyone please comment in the chat box? So 1/3 of the lateral to 2/3 of the medial is going to be fractured. So in the sense, if you see, this is the clavicle. So this is your lateral and this is the medial side. So 1/3 of the lateral and 2/3 of the medial will be damaged in the patients. Next, this is your femur. So here, this is the neck. Okay, this is the shaft. So what happened? If there is a fracture in the surgical neck, most nerve that is damaged here is the axillary. Okay, axillary nerve is damaged. If it is shaft, it is radial nerve. Okay, and vessels also can be asked in the examination. Posterior circumflex artery. Next, the arteries that is near the shaft is going to be profunda brachii, right? And if there is a radial nerve damage, the patient will also going to have the wrist drop. Next, coming to the nerve supply of a normal patient with the palmar side and the dorsal side. So this is going to be median nerve. On the palmar side, usually the median nerve is going to cover your thumb and the index finger and also middle finger. Next, on the lateral side, only the nails which will be covered by the median. Okay, median now. And ulnar is going to cover the little finger and also half of the fourth finger it is going to be covered. Right. Next, on the dorsal side, you are going to see this is the radial nerve which will be supplied here. Right. This can be also asked in the examination. Please don't forget to right. Next, moving on to the scapular conditions. So, this is a condition of the shoulder drop. So, shoulder drop is seen due to which nerve palsy? Shoulder drop is usually seen with the patient, those who are suffering from the spinal accessory nerve damage. Okay, spinal accessory nerve damage. And if this is also involved, sternocleidomastoid muscle is also going to be involved. Okay, if there is a nerve palsy, with the spinal accessory, both shoulder drop, trapezium will be involved, and at the same time, sternocleidomastoid muscle also involved. Next, this is known as a winging of scapula. Yeah, this is known as a winging of scapula seen in the long thoracic nerve damage. Okay, long thoracic nerve damage. Next, this is the Trendelenburg test. This is Trendelenburg test. So Trendelenburg test is positive in which patients? Usually there is a muscles gluteus maximus and gluteus minimus and gluteus medius, right? These are the intermedius, right? The gluteus maximus is going to be supplied by the inferior gluteal nerve, okay, inferior gluteal nerve, and these two is going to be supplied by the superior gluteal nerve. And this superior gluteal nerve, if it is damaged, the patient is going to be positive for the Trendelenburg test. So the tilt that you are seeing here, the tilt will be affected on the normal side. Okay, the tilt will be seen on the normal side. This is how the pressure will be affected in the normal patient. But the nerve fibers that is damaged here, there will be tilt onto the opposite side, which is normal. Right? This is how you have to understand this normal test of the patient. Next, moving on to the neural tube defects. So we all know that here the picture, this is the neural tube, how it is going to be formed. This is the cranial side and this is the caudal side. Let's see, understand first. And there are the two types, guys. One is anterior neural tube defects and also posterior neural tube defects. So the anterior, which will be affected at the time of 25th intrauterine life if it is defected, and exactly we can say third week of the embryogenesis, or next it is seen at the 28th day of the intrauterine life or fourth week of life. Okay, fourth week of the life. And most commonly associated effect is here anencephaly. What is mean by the anencephaly, guys? Here in the picture, here you can see this is the condition of the anencephaly. Okay, and on the ultrasound, frog face, lemon sign, these are the signs that will be seen in the anencephaly. Next, the most common in these patients, posterior, that is spina bifida, which will be seen in this patient. And most severe is going to be myelomeningocele. Okay, myelomeningocele. Next, if they asked most common overall, that is spina bifida. Okay, most common overall, the patients. Right, these are the some of the effects that will be seen in this patient. Next, what is the cause of this? The cause for this patient for the neural tube defects, most commonly folate deficiency. Okay, folate deficiency is one of the cause. But if they include multifactorial inheritance, multifactorial inheritance then better choose the multifactorial inheritance as a options. Okay, and how we are going to give the therapy for this patient, those who are having this condition, how we are going to treat this patient with the therapy of the folic acid. Okay, how we are going to give this folic acid for this patient. Basically, whenever you see these patients with the these conditions, normally we are going to start all the pregnant women with the 400 micrograms per day. Okay, we are going to start, and at least 1 month before we are going to have this condition. Next, but the patient with the neural tube defects history, if they are having the neural tube defects with the pregnancy, then we for this patient we are going to give the 4 milligrams per day, 4 milligrams per day, at least 3 months before we have to start. Before their conception, we are going to start. And also those who are taking the history of the seizure disorder, seizure medications, seizure drugs also, then also we are going to give the 4 mg per day that we are going to give. If they have the history of the sickle cell, then for this patient at least 5 mg per day we have to give. So this is the protocol that the folic acid should be given for this patient. Next, another picture here you can see, this is the action potential. So guys, action potential, last year one question was given from this. In the action potential, you have to understand what are the important phases. Okay, first in the phase 1 you are going to see what is the stimulus that will be started at the time of the resting membrane potential. When it is at the resting membrane potential, the stimulus will be started. So what is the most common stimulus that will be reacted from? Sodium, which will be influx into our cell and which will cause the further action potential reaction, which will be reaching for the plus 40 of the intrinsic factors, right? So this phase is going to be influenced by the sodium influx. Okay, and once it reach the certain point of the action potential, again it going to repolarize with the help of potassium outside. So the potassium is going to be efflux here, right? So again the positive ions coming out of our cell, which will be causing the repolarization. And next, from here you are going to have the, again if there is a excess of the potassium out, which will be causing this hyperpolarization, and again coming back to the resting state will be seen in this patient. Okay, this is how the action potential and different phases is asked. Next, we have the absolute resting membrane potential and also refractory type of the resting membrane potential. Okay, so absolute resting membrane potential, that means, sorry, refractory period, guys. Take note, this is the refractory period I'm talking about. So what is meant by the refractory period? So this is in the depolarization stage, and again here repolarization stage. This time you cannot disturb the action potential. Again it is going to change, but especially in the absolute refractory period, there will be no change. Regardless of adding anything, there won't be any change. But if there is a refractory type, or there, what happens here? So what happens? There will be some changes. Okay, there will be some changes that will be seen in the refractory period, which will be relative. Okay, that's the point that you have to take note. And also another point, all or none law. What is mean by the all or none law? What is mean by the all or none law means either there will be, okay, either there will be action potential or no action potential. Okay, so there will be action potential transmission or there will be no complete action potential that will be seen. Next, moving on to the another important point, here you can see this is both of the, this is the structure of the ventricle and this is the structure of the atria action potential. Let's see important phases of here. So let's see the first atria, how the atria is going to be reacted. Atria have only three phases. One is, here you can see, this is the fourth phase, and this is the zero phase, and here third phase. Okay, so in the fourth phase, there will be a potassium influx. Okay, there will be potassium influx, and here there will be calcium influx. Okay, calcium influx will be seen in the zero phase, and here the repolarization will be due to potassium out. Okay, this is how the atria, or we can say SA node action potential will be decided. Next, here you can see this is the ventricle. Again, there will be a different phases that will be seen here. So first, in the fourth phase, again there will be a sodium influx, and also zero phase sodium influx will be seen. Okay, sodium influx will be seen here, but here in the first phase there will be potassium out. Okay, and here also in the second phase potassium is out, but there is some of the channels calcium which will be present in the second phase, and this phase is also known as a plateau phase. Why? Because there is a steady state of maintenance for the maintenance of this resting membrane potential, which will be seen the calcium inside and potassium outside. And here there is a complete potassium out. So again, you are going to see the repolarization, right? And again, the phase is back to the resting membrane potential. Okay, these are the important points of the action potential that you have to remember. Next, we are going to moving on to the muscle contraction. So before we move on to the muscle contraction, I want you guys to know about the sarcomere structure. What are the important factors that is present here? So these lines is known as a Z lines. Okay, and this zone which is present here, this is the H zone. Okay, next, what about the thin actin and the thick myosin, which is known as, okay, so here these are the thick filaments that is present myosin. Okay, and these are the thin filaments that is present as a actin filaments. All right, so this is known as a I band. Okay, this is known as a I band, and here this one is known as a band, right? This is how we have marked Z lines, H zone, and I bands and A bands. So when there is a muscle contraction, how they are going to be formed? So actin is subdivided into according to its molecules. How it is subdivided? First, it is subdivided as a tropomyosin and also troponin and actin. Okay, so according to the situation it is going to bind, and troponin have three different. One is trop I, and other one is a trop calcium, and next just troponin. Okay, this is how they are presented. So when there is a action potential, when there is a action potential which will enter the T tubule, okay, it will going to enter into the T tubule. So near the T tubule there is a separate receptor that is known as a dihydropyridine receptor. Okay, these dihydropyridine receptor, along with the help of ryanodine receptor, along with the ryanodine receptor, they are going to enter into the sarcomere. So here in the muscle contraction, the sarcolemma, which is going to release the calcium. Okay, it is going to release the calcium. Once the calcium is released, here how it is going to bind. So the calcium is going to bind with the troponin calcium, right, in the actin, and the myosin from the other side, which will be activated with the help of ATP. So calcium and here myosin, which will be binding, will cause the cross bridge formation. Okay, it will form the cross bridge or sliding filament which will be formed. Okay, this contraction is known as a muscle contraction. Okay, during the muscle contraction, what happens, guys? What is the important points that you have to take note here? This is how the contraction muscle, so everything will be interlinked here. So A band is going to be intact. A band is not going to have any changes. Okay, that is your myosin. But I band, okay, I band, during the sliding chain it is going to shortens. Okay, it is becomes the shortens, and z lines is going to come closer, and the H zone which will be disappear. Okay, these are the changes that will be seen in this muscle contraction. Next, ryanodine receptor. So if there is a ryanodine receptor that will be dysfunction, which will be causing the malignant hyperthermia in the patient. Okay, increased temperature, increased BP, tachycardia, and severe fever that will be seen in this patient. And for this patient, we have to give the IV dantrolene. Okay, dantrolene sodium should be given immediately as an antidote. Okay, this is the overview of the muscle contraction. Next, moving on to the oxygen hemoglobin curve. In the oxygen hemoglobin curve, you have to understand for every one hemoglobin, there is 1.34 ml of the oxygen will be carried. Okay, that means 15 hemoglobin means 100 ml of the blood which will be carrying of 20 ml of oxygen per minute. That is how it is transmitted. And also take note of these points. Hemoglobin, which will be combined with oxygen, is known as a oxyhemoglobin. Okay, hemoglobin with carbon monoxide is known as a carboxyhemoglobin. Okay, this is known as a carboxyhemoglobin, guys. But how about carbon dioxide? Then this is known as a carbamino hemoglobin. Okay, next, if it is with the ferrous hemoglobin. This is known as a hemoglobin. This is the names of the different types. Next, here we have to understand that exactly the normal graph of the patient will be sigmoid. Okay, sigmoid curve will be seen. So either it is going to shift to the right side if there is a decreased oxygen. Okay, and it will be shifting to the left side if there is a increased oxygen affinity, right? So what are the changes? Exactly the normal point will be P50. Okay, it is going to be P50, right? Exactly at the 25, you are going to have the normal curve. Okay, this is the normal P50 or the 25 mmHg. And if it is shifted towards the right side, so more than P50, right? If it is shifted to the left side, less than P50. And what are the diseases that is associated, guys? Again, revise here. On the right side, you are going to see if there is a increased PCO2. Okay, if there is a increased temperature, and if there is a increased H plus ions, okay, that is going to cause the acidic nature. And also if there is an increased 2,3-DPG molecule that is increased. Next, left side of the shift, completely opposite. If there is a decreased PCO2 and decreased H plus ions, decreased temperature, or patients those who are with the hemoglobin, fetal hemoglobin that is present, right? These are the other types of the diseases, that is the shifting which will be seen in this patient. And also know about the what is the Bohr effect and the Haldane effect. Okay, so short, what is the Bohr effect, guys? It is seen at the tissues. That means high CO2 will be seen and O2 will be decreased, right? Next, we also have the Haldane effect. What is the Haldane effect? It is seen at the lungs region and alveoli. In the alveoli, you are going to have the oxygen which is very rich and which will be decreased by the carbon dioxide. This is known as a Bohr and the Haldane effect. Next, we are going to see about the sleep cycle. In the sleep cycle, there are the many waves that you have to understand. First, this can be asked in the examination, this pattern also. So before we go into this EEG pattern, we will see what are the types of the sleep cycle. So sleep cycle is divided into the two stages: non-REM stage, which is known as a non-rapid eye movement stage, and rapid eye movement stage. Okay, so non-eye rapid movement, which will be divided into the three stages, and this is just one sleep, which is also known as a paradoxical sleep. Okay, this is also known as a paradoxical sleep. First, whenever you are having in the awake time, you are not sleeping. During this, you are going to have the beta waves. Okay, this is going to be beta waves. Beta waves is more than 14 hertz. Okay, next, after that, you are going into the rapid eye movement stage. Here also, there will be beta waves, and the sleep cycle is just 25% only. And during the stage only, the sawtooth, okay, sawtoothing pattern will be seen on the EEG. Next, moving on to the non-REM stage. As I said, there are the three different stages. N1 is going to be very shortest stage, same like 25% of the sleep cycle. And here you are going to see the theta waves. Okay, these theta waves is 4 to 7 hertz. Okay, 4 to 7 hertz. And during this only, remember, you are going to have the hypnic or the myoclonic jerks. A myoclonic jerks will be seen in the patients. Next, N2 stage. N2 stage is the almost deep sleep. 45% of the sleep will be seen. And here you are going to see K complexes, okay, and also sleep spindles will be seen here. Next, N3 stage, you are going to see the delta waves, okay, delta waves in here, and the delta waves which is present here, how much is the delta waves going to have? Less than 4 hertz will be seen. Again the stage, again REM stage, and the cycle will be continue. On an average, about this cycle is 90 minutes, and cycle is going to move again and again and again, right? This is how the sleep cycle will be presented. And here the EEG pattern, when there is a awake, what are the waves that is going to come, guys? Beta waves. And in REM stage 1, you are going to have the what waves? Alpha waves. These are going to be 7 to 14 hertz. And N2 theta waves, sleep spindles, these are the sleep spindles, and sudden rise K complexes will be seen. So this is around 14 to 7 hertz will be seen. Next, less than delta waves, less than 4 hertz, and again NREM stage, again this is going to be beta waves which will be seen in the patients. Right, next moving on to the vitamins and minerals. In the vitamins and minerals, you have to understand there are the different types of the questions. There are easy questions can be asked in the examination, guys. You should not miss this important topic. Okay, first let's see what is this deficiency, guys. This is associated with the vitamin A deficiency, right? What are these spots? These spots are known as a white spots, and this condition is corneal ulcer if there is left untreated. Next, this is the pyrenoderma. Pyrenoderma is seen in the patients, again vitamin A deficiency. And what is this condition? This is the pellagra, right? This is the pellagra condition. And pellagra condition is seen in which patients, guys? Those who eat the maize and those who eat the sorghum. These patients you are going to see. And also associated with the carcinoid syndrome and Hartnup syndrome. Hartnup is a genetic condition that will be affected in the kidneys, right? This condition can be also seen with the pellagra-like symptoms. And also those who are having the decreased B6 and those who are taking the TB medications and severe alcoholics, they will be seeing this condition. Pellagra, which will be associated with the dermatitis, and also if it is left untreated, it is going to present with the diarrhea and dementia, and if you left untreated, that can result into the death also. This classic necklace is known as a Castle necklace sign, right? Castle necklace sign, and this is photodermatitis. Photosensitivity will be seen in this patient, right? One of the important points that you have already revised. Next, this is the mammillary bodies, and if there is a mammillary bodies that is involved in the inflammation or the necrosis, what is that condition, guys? This is known as a Wernicke's, right? Wernicke's condition seen in the chronic alcoholic patients where there is a deficiency of the B1 or the thiamine deficiency is seen in this patient, right? What is the symptoms that will be associated? GOA, global confusion, and also ophthalmoplegia will be seen in this patient, right? Next here, ataxia. And if you left untreated, this will convert into the coroscope. So in the coroscope, there will be confabulation, and also anterogate amnesia, which will be seen in this patient. This is the over the time of the B1 deficiency. But B1 deficiency not just present this way also, it can be present as a wet beriberi or the dry beriberi. Wet beriberi is seen in the heart patients. Dry beriberi is seen in the patients of the nerve injury. And this too is going to be seen in the patients those who are taking the polished rice due to the nutrient deficiency. And here B2 deficiency seen with the glossitis, cheilitis, and itching and burning. This is also known as a corneal vascularization. Okay, corneal vascularization will be seen in the patients of the B2 or the riboflavin condition. Okay, next another picture here you can see this is known as a scurvy, right? Scurvy condition. So this bleeding, gum bleeding, and also this PTK and decreased collagen all will be seen in the condition of the vitamin C deficiency. Okay, in the patients, those who are suffering from the vitamin deficiency, there will be a decreased collagen because the hydrolysis, most important step of the hydrolysis, is run by the vitamin C. If it is not present, then the condition will be associated with the scurvy. Next, here, this is the condition of the rickets. Rickets is due to decreased vitamin D, right? Decreased vitamin D. And how are the X-ray will be seen? Here, this is the fraying, guys. Okay, this is the fraying, and here you can see this cupping will be seen, and flaying, okay, spraying. This condition which will be associated with the vitamin D deficiency. And on the labs you are going to see there will be decreased calcium levels, decreased phosphorus, and increased parathyroid hormone, and also decreased ALP, okay, which will be seen in this condition, right? This is the rickets and rachitic rosary, which is painless, okay. And in the scurvy you are going to see other one, scorbutic rosary. Okay, scorbutic rosary is very painful. Okay, same region, costophrenic angle, you are going to see here only the bleeding appearances. Same, but in the rickets it is painless, and in the scurvy it is going to be painful. Okay, these are the one of the example that you have to remember. Next, this is going to be B12 deficiency. Okay, B12 deficiency, and here this is the folate deficiency. Right, neural tube defects. Just now we discussed neural tube defect, birth defects that is seen in this patient. Next, another thing that you have to remember, what is the difference that will be seen in the patients of the vitamin B12 and the B9 deficiency? Both are going to be anemia only, but B12 is most commonly seen in the vegan patient. And on the exam and on the labs, you are going to see this patient homocysteine levels, okay, homocysteine levels, and along with that methylmelanoconic, okay, methylmalonic acid, both are increased. And folate is seen in the patients of the alcoholics, seen in the alcoholics. Here homocysteine is raised, okay, homocysteine is raised, but normal methylmelanonic acid, that is the difference between the folate and the vitamin B12 deficiency. All right, next, here this is the condition of the zinc. Okay, what is this condition, guys? This condition is known as a acrodermatitis enteropathica. Acrodermatitis enteropathica. Okay, this is seen in the patients, especially those who are suffering from the genetic condition. Okay, this genetic condition will be seen in this patient, and the patient will be having the rash, and also zinc will be important for the GIT. There will be suffering from the diarrhea, and symmetrical rash you are going to see. Okay, symmetrical rash you are going to see in this patient. That is the condition of the zinc related acrodermatitis enteropathica. Next, we have the Menkes, and other one is the Wilson, right? These both are related to the copper. So Menkes disease is going to be ATP7A gene mutation, and Wilson's is ATP7B mutation. Okay, and this is an X-linked condition. This is an X-linked condition. Here it can be autosomal dominant condition, right? So in the Menkes disease, you are going to see the copper is decreased. This patient, copper is decreased. So the patient will be having the kinky hair, and also seizures, hypotonia will be seen. And Wilson's disease, there is an increased copper. So the patient will be having the liver cirrhosis also. And if they also include the CNS, it will be very detrimental. And the classic sign, KF ring sign, you are going to see in this patient, right? This is also one of the things that you have to remember, right? These are the things that you have to take mind, guys. And here another test that you have to take note. For the vitamin B1, it is RBC transketolase. Vitamin B2, RBC glutathione reductase. Vitamin B6, RBC transaminase. B9, Figlu test or the histidine test. B12, it is serum methyl malanoid test. Okay, these are the serum assays that you have to take note. And one more thing that we are missing here, what is that condition, guys? Especially it is B6 deficiency. Okay, B6 deficiency. And the patients, those who are suffering from the B6 deficiency, mostly those who are taking the isoniazid TB drugs, or it can be genetic acquired, and those who are suffering from the sideroblastic anemia, there will be increased toxicity. Okay, and also if there is a deficiency, which will be also seen, only the water soluble vitamin which will be having both. and both presentations is also going to be peripheral neuropathy. Okay, peripheral neuropathy is seen in this patient, right? This is the one differences that you have to take note, right? These are the important points, guys. And another thing that you have to take note, the vitamins and the active forms. Okay, let's see some of the important vitamins and active forms that you have to take note. In the vitamin A, the active form is the retinoic acid. Okay, it is due to retinoic acid. Next, vitamin D. Okay, vitamin D, the active form is the calcitriol. Okay, vitamin E, it is tocopherol. And vitamin K, hydroquinone. Hydroquinone, right? Next, another things here, the B1. The B1 important one is the thymine pyrophosphate. Thymine pyrophosphate. Okay, next here B2. B2 there is a pad that will be presented, and B3 niacin, nicotine, and next B5 coenzyme A, which will be consisting of the coenzyme A, and B6 it is going to contains the pyrophosphate, pyridoxal phosphate, pyridoxical phosphate, and B7. Okay, another one B7 is biotin enzyme which will be presented, guys, and B9 B12. Okay, let's see here. The B9 which will be B12 is going to consist of methylcobalamin active form. Okay, methylcobalamin active form, and B9 it is going to consist of the tetrahydrofolate. Tetrahydrofolate, the name itself contains. Next, remember another point, guys, if there is a B12 deficiency, it can cause a severe combined degeneration also. It is a complication. Next, zinc is also going to help in the wound healing. So if there is a zinc deficiency, there will be poor wound healing. Another vitamin that is associated here this one. So here also you are going to see the poor wound healing in this patient. That is also seen in the patients of the scurvy. Next, moving on to the amino acid disorders. Okay, first in the amino acid disorders, you have to take note these important points. First, this is the condition. Here you can see what is this condition. The black urine disease is on the sclera. There is a blackness, and also here the onchronosis. All these condition which will be known as your onchronosis, right? Onchronosis. These onchronosis is seen in the patients of the alkoptonuria. Okay, alkoptonuria. What is the enzyme that is deficiencies here, guys? Homogentic acid. Homogentisate acid oxidase. That is deficiency in this patient. Next, here you can see this is the condition of the albinism. Okay, complete absence of the tyrosine. Okay, complete absence of the tyrosinase deficiency. Next, this condition is known as a phenylketonuria. Phenylketonuria. And phenylketonuria is the most common worldwide inborn error of metabolism, autosomal recessive. What is the deficiency that is present here, guys? Phenylalanine, phenylalanine hydroxylase. Hydroxylase, that is deficiency in this patient. So there will be increased phenylactate and increased phenylacetate and also increased phenyl ketones. That the why the patient will be associated with the mental retardation and also pigmentation and musty odor. Okay, the musty odor smell of the urine will be seen in this patient. Okay, that is a finding about the phenylketonuria patients. Next, moving on to the another condition. This condition is known as a Marfan's syndrome. Okay. In the Marfan syndrome, what is the deficiency, guys? Fibrillin 1 gene that is deficient in this patient. And this is the most common autosomal dominant condition. The patient will be having the features of the tall and slender. This kind of the skeletal will be seen. And this patient, mental retardation is not seen. They are going to be normal only. Next, coming to the lens, there will be ectopic lens. How the lens will be seen, guys? Upward. Okay, lens are going to be upward and temporal side there will be seen, and patients will be associated with the mitral valve prolapse and also aortic dissection. Okay, aortic dissection. Premature death is most likely due to aortic dissection only. And next here, another picture. This is known as a homocystinuria. Homocystinuria condition. This is autosomal recessive. And this patient will be having the deficiency of the this patient will be having the cystothionine synthase deficiency. Okay, same patients, tall, skeletal muscle deformities, but this patient will be associated with the atherosclerosis. And lens dislocation is commonly seen as a down and nasal that will be seen. And the major difference between the Marfan syndrome and the patients, those who are suffering from the homocystinuria, the test we are going to produce cyanide nitroprusside test, which will be positive in the homocystinuria, and here the cyanide nitroprusside test will be negative in the patients of the Marfan. This is the galactosemia, right? This is the galactosemia. The deficiency is due to GALT gene. Okay, GALT gene deficiency is seen. Next, this is known as your Lesch-9 syndrome. Okay, self-mutilation, mental retardation that will be seen. What is the enzyme here? HGRPT gene that is involved in this patient, right? Oil drop cataracts that will be seen in the patients of the galactosemia. Next, another important points that you have to know, some of the other types. Okay, first one is going to be maple syrup disease. Okay, the maple syrup urine disease, this patient is deficiency of the branched chain keto acid hydroxylase, which will be deficient in this patient. Okay, so what are those branched chains, guys? So isoleucine, leucine, and valine, these are going to be seen in this patient. Next, thyrosinemias. Okay, first tyrosinemia 1, the patient will be having the hepatorenal syndrome. Okay, they are going to have the hepatorenal syndrome, and this is due to deficiency of the fumarate acetoacetate. Next, tyrosinemia 2. This is oculocutaneous. This condition is consist of the oculocutaneous. What is the enzyme that is deficient here? The name itself tells tyrosinase transaminase. Okay, tyrosinase transaminase that is deficient. Next, tyrosinemia type 3. And here EHPP dioxygenase that is seen in the especially in the neonatal tyrosinemia type. Okay, these are the some of the types inborn errors that you have to remember. Next, you also have the Rifsum disease. Okay, Rifsum disease. What is this Rifsum disease, guys? Rifsum disease is associated with the increased or decreased, there will be peroxisomal disorder. So if there is a increased phenol coenzyme due to deficiency of the pitenic acid that is seen in the Rifsum disease. Next, Zellweger disease. Okay, there is another condition, Zellweger disease. This is due to deficiency of the peroxisomes. Okay, peroxisomes is deficient in this patient. So it will involve the hepato, and also it will involve the kidney, renal, and it is also going to involve the CNS, right? Cerebrohepatorenal condition that is known as a Zellweger disease. Next, moving on to the genetic disorders. Okay, in the genetic disorders, you have to take note what are the important points that you have to see. First, in the genetic disorders, let's see from the autosomal dominant. So in the autosomal dominant, there will be no skipping of generation. So there is no skip of generation. Here you can see affected, 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 right? And next, there will be incomplete penetrance. What is mean by the incomplete penetrance? That means it is transmitted, but not all going to be show the symptoms. So the symptoms which will be shown as a variable symptoms will be seen in this patient. Next, moving on to the autosomal recessive. So in the autosomal recessive, there will be carriers which will be presented. So they are not going to show the symptoms. So they are going to be homogeneous, but they are going to transmit by skipping of the generations. Okay, So not the all generations will be involved. With the help of the carrier, other generation will be involved in this patient. Next, X-linked recessive. Here most commonly the female will be the carrier. Okay, female will be carrier. Mostly they are going to affect the males, that is X-linked recessive. Next, X-linked dominant, the males is going to be carrier, the males are going to be carrier, and they always affect the females. Okay, they always affect the females. Next, coming to the mitochondrial, and here the only mother is going to transmit to son and daughter. Okay, son and daughter, that is transmitted from the mother, that is known as a condition mitochondrial inheritance. Next, moving on to the other examples, guys. Here, Down syndrome. In the Down syndrome, what are the features? Simian crease, hypotonia, umbilical hernia, congenital heart diseases, mental retardation, abundance of the skin, and epicanthal fold. All this will be seen in this patient. Next, coming to the cardiovascular risk in this patient, the most common acyanotic, okay, the most common acyanotic will be AST, okay, or VST, but you have to choose the endocardial cushion defect. Endocardial cushion defect will be seen. For example, if it is a cyanotic condition, then tetralogy of Fallot will be seen in this patient. Next, coming to these patients, there will be leukemia. The most common type will be ALL, that will be seen in this patient. But if the age is 3 years less than, then it is AML M type 7, that will be seen in these patients of the leukemia. Hypothyroidism, all other symptoms like SNHL, everything will be seen in this patient. Next, trisomy 18, Edwards syndrome. The patient will be having the micrognathia and mental retardation, prominent occiput, congenital heart diseases, VST will be the common, and here the renal malformation like horseshoe kidney, overlapping fingers, and here you can see the rocker bottom feet, that will be seen in the Edwards syndrome. Next, Patau syndrome, the patient will be having the cleft lip, cleft palate, microcephaly, mental retardation, polydactyly, and microophthalmia. And again, the renal defects like cystic ducts will be present in the condition. And this is the one of the condition, Patau syndrome, 13th chromosome. And here chromosomal defect, for example, here you can see Klinefelter syndrome, 47XXY. There is a extra X. Turner syndrome, there is only one X that will be affected. The patient with the Klinefelter, tall stature, poor beard, and also there will be a pubic hair pattern, testicular atrophy, and the patient will be having the breast development, that is seen in the patients of the Klinefelter. Next, when it is comes to the Turner syndrome, Weber neck, short stature, and normal IQ will be present in this patient. Underdeveloped breast, streaky breast, and there will be a very wide range between the nipples, rudimentary or the streaky ovaries. There will be nevus formation, that is seen in the patients of the Turner syndrome. And here you can see this is the DiGeorge syndrome, right? In the DiGeorge syndrome, this is mostly due to third pharyngeal pouch, that is the defected in this patient. What is the chromosome? 22 short arm that will be affected in this patient. So there is a mnemonic catch. Okay, there is a mnemonic catch. So catch means C for the patient will be suffering from the cleft. Okay, the cleft will be seen in this patient. Cleft lip or the palate will be seen. Next, the face which will be looking abnormal. Okay, abnormal faces that will be seen in this patient. Thymic hypoplasia. Okay, because third pharyngeal pouch is involved. Next, C for cardiac effects, the most common is the TOF. Next, hypocalcemia. If there is a hypocalcemia, seizures will be commonly seen in this patient because that pharyngeal pouch going to have the parathyroid glands. If the parathyroid glands is defected, the patient will be having the hypocalcemia that will be seen in this condition. Next, opposite to the Turner, there will be Noonan syndrome. Okay, Noonan syndrome, the patient will be having the mental retardation with the Weber neck. Okay, with the Weber neck that will be seen in this condition. And another one will be pulmonary stenosis. Okay, pulmonary stenosis will be seen. And those who are suffering from the patients, those who are suffering from the Turner, there will have the coarctation of aorta. Coarctation of aorta, which will be seen in this patient. Right? These are the diseases of the genetic condition. And also you have to take note of the examples, guys. Please do refer the pathology notebook and refer the importance of the autosomal dominant, recessive, X-linked, and their examples also you have to take note. Okay. Next, we will see the paternal and the maternal deletions also. Let's see first paternal deletion, which will be P for paternal and P for Parder-Willi. Okay, P for Parder-Willi. And maternal deletion, which will be seen with the Angelman syndrome. Okay, Angelman syndrome. What is the disomy that is present? Paternal is absent, right? Next, here you are going to see the maternal disomy. Okay, maternal disomy. And here maternal is absent, then paternal disomy, which will be seen in this patient. Maternal deletion, paternal deletion. These are the difference of the one of the two important examples. Next topic we are going to discuss is the oxidative phosphorylation. In the oxidative phosphorylation, there are the five important complexes, guys. So each complexes is going to have the inhibitors. What are the inhibitors? For the complex one, the inhibitors are going to be bigonides, okay, bigonides, and also barbiturates, and rotinoid poison, and pecidin. Okay, pecidin. These are going to be the type 1 complex 1 inhibitors. Next, complex 2. The inhibitors are malonate and carboxin. Okay, carboxin. Next, third one, complex 3 is going to have the antimycin and BAL. Okay. Next, complex 4. What are the inhibitors for the complex 4? Is commonly asked question. Cyanide, okay, hydrogen sulfide, and also carbon monoxide. These are going to be the fourth complex inhibitors. Next, we have the last one, which is fifth complex inhibitors are oligomycin. Okay, it is oligomycin. Next, they are uncouplers also, physiological uncouplers. What are those physiological uncouplers, guys? Especially thermogen. Okay, thermogen is going to be play the increased temperature, which will cause the uncouplation. Next, thyroid. Again, thyroid high because it will increase the basal metabolic rate. Next, bilirubin can also raise the metabolic rate in the body, and also lipids, right? These all going to be the physiological uncouplers of the patient. Next, we are going to discuss about the glycogen storage disorders. Here you can see the type 1 is going to be the most common type, which is deficient of the glucose 6 phosphate, and most common type the presented as this much hepatomegaly that will be seen in this patient. Along with that, lactic acidosis, hyperlipidemia, hyperuricemia all will be seen. Next, type 2 is a Pompe disease. This is lysosomal acid alpha glucosidase will be in deficiency, and patient will be Pompe. Remember this way as pump. So cardiomegaly, heart failure will be seen in this patient. Next, type 3 CD, Cori disease, D branching enzyme. Type 4 AB, Anderson and branching enzyme. So these both are going to be also same. Okay, D branching enzyme, hypoglycemia, hepatomegaly, muscle weakness. Next, Anderson, same. This is going to be hepatomegaly, but progressive cirrhosis, hypoglycemia, varices ascites will be seen in the children patient. Next, type 5, McArdle and muscle phosphorylase. And type 6, HERS and hepatic phosphorylase is the enzyme deficiency. Next, LSDs. Okay, lysosomal storage disorder. Here you can see Tay-Sachs disease, hexoaminase A deficiency, and there will be the Tay-Sachs disease, which will be showing the cherry red spot on the macula. This is the most common association for the cherry red spot. Next, Gaucher disease, the most common overall all types of the LSDs, and the enzyme G for Gaucher, G for glucocerebrosidase. Next, Fabry disease, alpha galactosidase, Krabbe cerebrae sidase, galactocerebrosidase, and on this you are going to see this kind of globoid cells which will be seen in this patient. Next, Fabry disease, this kind of acropathisias and this angiokeratomas will be seen in the patient. Next, Gaucher disease, you are going to see the specific finding like tissue paper crumpled appearance you are going to see. Okay, next, Niemann-Pick disease, pingomyelinase, that is the deficiency of the patient. Next, this is the mucopolysaccharides. The types are hunters and hurlers, which is the most commonly asked. Hunter patient, eyes is very good, that the patient will be having no eye defect. And patient with the hurler, they are going to have the idironeides, which will be deficient, and the patient will be having the defect with the eyesight. Okay, that is seen in the hurler, and hunter will be seen with this condition. Next, another important points that you have to remember about this condition. What is the most common? Okay, most common among all will be the Sanfilippo. Okay, Sanfilippo, this is the most common type of the mucopolysaccharidosis. And in that X-linked, okay, this is going to be the X-linked type. Okay, this is the X-linked type of the Hunter syndrome which will be presented. Right, next moving on to the STD diseases. So here we are going to see the discuss about the STD diseases, guys. Basically in the STD diseases, the commonly asked questions will be the STD kits or their specific symptoms. Okay, let's see one by one. So first one, here you can see this is the syphilis. This condition is known as a, sorry, so this is syphilis, guys. First, we will discuss the syphilis. So, on the syphilis, what is the cause, guys? Trypanosoma pallidum. Okay, Trypanosoma pallidum is going to be the cause, and this patient will be present as a painless chancre. Okay, the painless chancre. And coming to the patient's lymph adenopathy, it is going to be bilateral lymph adenopathy which will be presented, and that is going to be rubbery in the texture which will be presented. Next, this is looking like a very dark one. D for dark and D for ducre. Okay, so hemophilus ducre is presented in this patient. So this is going to be painful ulcer. Okay, painful ulcer, and that's why it is also known as a chancroid. Painful chancroid that will be presented, and it will bleed on touch. And next, lymph adenopathy. Lymph adenopathy is also painful. Painful lymph adenopathy. Here it is painless, guys. Okay, it is painless. Next, here you are going to see the classical condition. This is due to LGV. Okay, this is due to lymphogranuloma venerum, and causative organism for this patient is the chlamydia, right? And especially this sign is known as a groove sign. Okay, this is the positive groove sign. Patient will be having the painful buboes. Okay, painful buboes which will be seen in this patient. Next, coming to the last one, this is the beefy red appearances, and this is known to cause by the Klebsiella. What is this condition, guys? Donovenosis. Okay, donovenosis. Klebsiella granulomatous is the common cause, and this is painless. This is the painless condition, and no pseudobubos which will be seen in this patient. Right, what is the drug of the choice for this patient? For the patient those who are suffering from the chancroid, we can give the drug of the choice azithromycin. Okay, this is given the azithromycin, and here the drug of the choice is the penicillin. Okay, and here drug of the choice is the doxycycline. Okay, doxycycline, and in this patient we can give the same again, azithromycin, that will be given for this patient. And the specific signs, if you want to see the signs, this is going to be positive on the culture, fish or railroad appearances, fish or the railroad appearances. And here darker microscopy is going to be positive in this patient, and chlamydia, right, nuclear amplified test which will be positive. And here also culture, on the culture you are going to see the Donovan bodies. So no one bodies which will be seen in this patient. Next, coming to the STD kits. Kit 1 is going to be in the green gray color, usually given for the patients of the urethral discharge, vaginal discharge, and scrotal swelling. And what is the drug? Azithromycin and the cefixime. Next, kit 2 green, which will be given for the vaginal discharge only. Okay, for the vaginitis. And the sucandazole or the fluconazole, which will be given for this patient. Next, white kit is for the genital ulcers, especially syphilis or the chancroid. Benzodine penicillin and the azithromycin is given in this. Next, blue kit is for the genital ulcer disease, only for the patients who is unavailability and history of allergy for the benzodine penicillin. For this patient, doxycycline can be given. Next, red kit is for the patients those who are suffering from the herpes. Okay, this is acyclovir is given. Yellow is for the lower abdominal pain and the pelvic inflammatory disease. And black kit is for the inguinal bubo and genital ulcers disease, especially LGV, doxycycline. And kit 8 recently added, this is for the anorectal discharge which will be given. Right, these are the STD kits. Next, vaginal infections. Here you can see this is the most common overall, that is the Gardnerella bacterial vaginosis. Next, how the discharge is going to present it, guys? Grayish white fishy odor which will be seen, and the patient will be having the strong fishy odor which will be seen, right? And on the clue cells which will be seen with the epithelial cells coated by the bacteria, and metronidazole is the drug of the choice for this patient and don't need to treat the partner. Next, candidas which will be present as a cottage cheese and there will be severe itching. Okay, severe itching will be seen in this patient. And on the history, budding yeast, pseudohyphae will be seen. Fluconazole is the drug of the choice, no need to treat the partner. Next, trichomonas is known as a STD due to the protozoa Trichomonas vaginalis and frothy yellow color green which will be seen in this patient and there will be musty odor. Okay, pH is also raised here. And the drug of the choice for this patient again metronidazole. As this is a STD, you have to treat the partner and strawberry cervix is seen on the examination. Okay, next moving on to the alcohol use disorder. So in the alcohol use disorder, you have to take note. First, is it about the withdrawal or is it about the patient or the examiner is asking mainly about the what is the importance withdrawal symptoms or what are the drugs that we have to give for this patient that you have to find. Okay, first important things we will note here guys. First, how the patient is going to be presented. Okay, alcohol use disorder, what we discussed, usually these substance induced disorders, most commonly this patient, they are going to be chronic alcoholics. Okay, and mostly 90% of the alcohol is observed in the small intestine. Okay, it is observed in the small intestine where metabolism of the alcohol, where the metabolism of the alcohol is seen in the liver. Okay, so how the alcohol is going to convert it guys. First, alcohol is in the form of the ethanol, right? This ethanol is going to converted as a aldehyde. Okay, it is going to converted as a aldehyde with the help of alcohol dehydrogenase. Okay, this is going to converted as a alcohol dehydrogenase. And remember another point for this patient, those who are having the blood alcoholic concentration, if it is more than 200, the patient will be having the complete 200 to 300, let's say 200 to 300, they can go into the coma and even death. Okay, this is going to be seen in the if the blood alcohol concentration more than 300 to 400. Next, let's see the withdrawal symptoms. Okay, let's see withdrawal symptoms of this patient. So if the patient is having just tremors, okay, if the patient is having the just tremors which is less than 6 to 8 hours after the withdrawal. Okay, this is seen commonly in the patient. Next, after that, the often patients will be associated with the hallucinations. Patient will be associated with the hallucinations. How these hallucinations will be presented in the form of auditory. Okay, in the form of auditory, it is going to see. Okay, this is around 8 to 12 hours from the withdrawal, right? And the patients now is going to presented with the seizures. Okay, GTCH seizures will be present in this patient. This is around 24 to 48 hours. Okay, next delirium tremens. Okay, delirium tremens, and these symptoms is specifically presented in the patients when the patients is going to have more than 48 to 72 hours. Okay, more than 48 to 72 hours. Okay, what is the drug of the choice for this patient? Those who are suffering from the this condition, we have to give the benzodiazepines. Best drug, the lorazepam can be given for this patient. And delirium tremens, which is a severe condition, for this patient also we have to give the benzodiazepines. But long acting drug should be given for this patient. For example, long acting drug that is chlorodoxyperoxide. This should be given for this patient, right? Next, how can we prevent this condition, right? How can we treat this patient? Basically, we have to choose for the long-term maintenances. So long-term treatment, which will be given in the choice of the patient. Commonly, what we use, guys, disulfiram. Okay, disulfiram drug will be given for this patient, and this disulfiram is going to block the alcohol dehydrogenase. Sorry, aldehyde dehydrogenase. It is going to block. So once it is going to block, the patient will be having the deterrent effects. Okay, deterrent effects. What is mean by the deterrent effects, guys? Basically, the chest pain. Okay, the chest pain will be seen in this patient, increased BP, and also patient will be having the sweating. Okay, dizziness. So these kind of irritations will be seen in this patient. And disulfiram like reaction can be seen with the drugs like metronidazole. Okay, metronidazole kind of drug, and also it is seen with the some of the cephalosporin drugs. Okay, some of the cephalosporin drugs. At least remember this one, metronidazole. And another drugs we can give is the baclofen. Okay, baclofen can be also given for this patient. Next, if there is a poisoning like methanol poisoning, if there is a methanol poisoning, we can give the fomepizole. Okay, famipizole as an antidote we can give for this patient. Next, another thing that you are already remember, if there is a wernicase, if the symptom is associated with the wernicase, progressed to the chorus cough, what we discussed in the vitamins, for this patient, the drug of the choice is the thiamine. Okay, thiamine should be given for this patient. Next, moving on to the sexual perversions. So, sexual perversions, which is also known as a paraphilias, guys. So, in the paraphilias, you have to remember all important direct question can be asked from this paraphilias. Okay, let's understand some of the paraphilias, like for example exhibitionism, voyeurism, and these kind of important points that you can be seen in this patient. Okay, so let's see what are those examples, guys. First one, which will be known as a, let's see, the first one we are going to discuss now is going to be exhibitionism. Okay, it is going to be exhibitionism. In the exhibitionism, the patient is going to show the genitals in public. That is known as a exhibitionism. Okay, next, necrophagia. Okay, necrophagia, this is eating corpse. Okay, eating corpses. Necrophilia, this is sex with corpses. Okay, next, those who are suffering from the voyeurism. Okay, this is commonly seen with the every person, that is peeping into others life. Okay, peeping into other sex life, they are going to get the sexualism. Next, fetishism. Okay, next it is fetishism. So fetishism, it is about objects. So objects used for the patients, for the non-genital objects they are going to use for the sex pleasure. Next, another one, masochism. Masochism is from the receive the pain. Okay, this is receive pain. Next, sadism, show the pain. Okay, this is showing the pain to the partner. Showing the pain to partner. This is known as a sadism, right? Next, we also have the voyeurism. What is mean by the voyeurism, guys? Voyeurism is usually due to patients, those who are rubbing the genitals. Okay, rubbing the genitals in public, in the public places for the other people. If you are rubbing the genitals, that is known as a voyeurism. Okay, next, there are many other also. For example, pyronemia, or the patient is doing the transvertism. This can be also asked in the examination. Transvertism, this is actually wearing the other gender change clothes. Okay, the patient is using the other gender clothes for the sexual gratification. Okay, these are the some of the important points, sexual perversions, that you have to take note, guys. Next, moving on to the hypersensitivity reactions. So in the hypersensitivity reaction, what are going to be these types of the hypersensitivity reaction? Let's understand what are these, guys, and this is going to be very important. At least examples you have to understand. First, type 1 is going to be IgE mediated. Okay, this is known for the IgE mediated, and in this IgE mediated, most commonly they are increased number which will be associated with the eosinophils, right? They are associated with the eosinophils. So it can be known as a anaphylactic immune allergic type of the hypersensitivity. Examples are anaphylaxis, seasonal allergies, hay fever, food allergies such as shellfish, peanuts, hives, and the eczema. Okay, and also you can add the asthma. This is also considered as a type 1 type of the allergic reaction. Next, type 2 hypersensitivity reaction. It is associated with the IgG cytotoxic. Okay, basically they are going to associated with the antibiotics, right? They carry the antibiotics and going to attack especially in the cell membrane layer. And what are the examples, guys? Most of the patients with the blood transfusion, okay, most of the blood type transfusion, this is all going to be in the IgG. And along with that, myasthenia gravis, good pasture syndrome, and patients those who are suffering from the Graves disease, right? This is the pemphigus vulgaris or the pemphigus foliaceus. This all will be considered in the patients of the this condition. And remaining platelets and reactions, every blood reaction, blood disease, anemias, all will be coming under the type 2. Next, type 3, type 4. So type 3 is immune complex. Both the antibody plus the antigens is going to be presented here. What are the examples? Glomerulonephritis, rheumatoid arthritis, systemic lupus condition, and Henon's clinics purpura, reactive arthritis, and patients those who are suffering from the Arthus reaction. Okay, Arthus reaction, post streptococcal glomerulonephritis. Next, lepra type 2. Lepra type 2 reaction is also seen. 2 plus 3, that is going to form the 5. So rule of 5 for the lepra reactions that you have to remember. Next, type 4 plus only 1, right? It is going to be become the 5. So lepra type 1 is going to be associated with the type 4. So this is going to be delayed, guys, very much delayed cell mediated type. And here the common are contact dermatitis, tuberculin reaction, and autoimmune diseases such as diabetes mellitus type 1, multiple sclerosis, and also rheumatoid arthritis. You might be consisting rheumatoid arthritis is present here and there, but better choose the rheumatoid arthritis in the type 3 only. Okay, and lepra 1 reaction is also seen in the type 4. Next, moving on to the cellular injury and the inflammation. In the cellular injury, you have to remember first what are the important points. First, what sorry guys. So first, cellular injury, the normal cell which will be going under the stress, which is going to cause the cellular injury, and this cellular injury is going to be reversible. Okay, and what are the changes like membrane blebbing and mitochondrial swelling, cellular swelling, nuclear clumping? This will be seen. And when it is going to become the irreversible, when it is going to become the irreversible condition, it is going to show this kind of pycnosis, condensation, or the karyorehesis, fragmentation, karyolysis. So either it is going to under the apoptosis, okay, or it is going to go under the necrosis. This is seen in the patients of the irreversible. And on the electronic microscope, you are going to see the changes which is known as a amorphous, okay, amorphous fluctuant densities, which will be seen. This is nothing but there is a mitochondria that is already destroyed in the cell. That is what's seen in the patients, especially when it is comes to the irreversible injury. Next, the question this can be also asked in the examination, guys. What is that question? Inflammation. So for this inflammation, how we are going to arrange? Okay, the arrangement can be asked in the examination. First, what are the events and how it is going to be formed? So the first acute inflammation is going to start with the vascular events. So vascular events such as vascular permeability, which will be seen, and this is considered as a hallmark. This is considered as an acute inflammation hallmark. After that, there will be a margination. There will be a margination, which is also known as a pavement. Okay, and next after that, there will be a rolling. Okay, rolling and adhesion, which will be seen. And next, e-migration, also known as a diapedesis. From the membrane they are going to, from the plasma membrane they are going to move to the other side, right? Next, there will be chemo attraction, so chemotaxis, and after that there will be phagocytosis. This is how acute inflammation will be done. So here you can see this is the events. First, there is a, this is the blood vessel, right? What happens? Immediately there will be a vasoconstriction. Okay, after the vasoconstriction there will be more vascular permeability. And what happened? This particular cell which is affected, that is going to come towards the, come towards to the endothelium, and this is what the margination or the pavementing. After that they are going to rolling, and for the rolling they have this factor Cialis levis. C Cialis levis and integrins is going to helpful for the patient's rolling, that is known as a selectins. Okay, and again they are going to be others. Okay, this is known as a adhesion, and for this adhesion we have this specific molecules VCAM. Okay, the VCAM is going to helpful for the adhesion. Okay, VCAM is going to helpful for the adhesion. And after that this is going to be diapedesis. Diapedesis is helped by the CD31 or the PECAM1, that is going to helpful for the diapedesis. And cytokines, we all know that there will be endo or the exo. For the endotypes, leukotrienes, IL-2 complements, that is going to be helpful. Okay, these are the important points for the what are the events that is going to be seen in the acute inflammation. Next, moving on to the diuretics. Okay, in the diuretics you have to take note first what is the site. So here you can see this is the carbonic anhydrase acetozolamide in the proximal convoluted tubule. Next, this is the mannitol where osmotics are engaged, and thick ascending loop of Henle. Here loop diuretics which will be furosemide, and next DCT thiazides and collecting tubule potassium sparing diuretics which will be affected. So let's see some of the important carbonic anhydrase inhibitors. What are the examples, guys? Acetozolamide, right? Acetozolamide. In this patient, what is the common use we are going to use? Expe- Especially glaucoma, and also patient those who are suffering from the high altitude sickness, right? What is the side effects associated with this patient? RTA can be seen, and calculus, especially renal calculi will be seen, and also metabolic acidosis will be seen in this patient. Those who are sulfa allergic, we should not give this drug. Next, coming to the osmotics. Okay, osmotics, commonly the drug is mannitol. Those who are suffering from the increased intracranial pressure and those who are suffering from the head trauma, we can give this mannitol. And which patients it is contraindicated, especially heart failure patient, we should not going to give this drug. Next, loop diuretics. Okay, example is furosemide, and furosemide is commonly given for the patients of the edema and also hypertension cases. And side effects, as I said, loops lose everything, so all the electrolytes that is present is going to be decreased, and increased glucose, and another G, increased gout. Okay, that is seen with the loop diuretics. Next, thiazides. Okay, thiazides, these thiazides, whichever the drug that will end with the thiazide, it is considered as a thiazide drugs, and this is commonly used for the nephrogenic diabetic insipidus patient, hypertension patient, and also end stage renal disease also we can do this thiazide drugs. And what are the side effects? Loops lose everything, thiazides also lose everything, but calcium is going to be normal. Okay, remaining, other than that, everything will be decreased in this patient, right? Next, again, there will be glucose is increased, and also gout reactions is also seen in this patient. Next, another points about the thiazides, and also for the patients of the loop diuretics, what are the metabolic effects? What you are going to see in this patient? Metabolic effects. So the metabolic alkalosis is seen. Okay, metabolic alkalosis which will be seen in this both patient. Next, last one, the potassium sparing drugs. Okay, potassium sparing drugs, spironolactone. Okay, spironolactone, common uses for this patient is the Conn's syndrome and resistant hypertension patient, and also those who are suffering from the ascites. This patient, we are going to give the spironolactone. What are the side effects when there is a potassium sparing? So increased potassium, which will be causing the heart arrhythmias will be seen in this patient, and also impotence. Impotence is due to, these are the blockers of the androgens, so also cause the gynecomastia. Okay, gynecomastia is also seen in this patient, and metabolic acidosis will be seen, right? These are the important points that you have to take note about the diuretics. Next, oral hypoglycemic drugs. So best examples oral hypoglycemic drugs, guys. Here you can see the most important biguanides, the drug of the choice for the diabetes mellitus type 2. And what is the mechanism? It is going to decrease the hepatic glucose production and increases the insulin sensitivity. Side effects for this patient, lactic acidosis, B12 deficiency. And remember, if it is less than 30 mg per ml, GFR should not be given. Next, sulfonylureas, it will going to block the potassium channels and secrete the insulin secretion. Weight gain is seen, highly potent of the hypoglycemia. So that's why it is not given in the patients of the heart diseases patient. Next, meglitides, same as the potassium channel blockers, but it is short acting. So weight gain, hypoglycemia seen here also. Next, DPP4 inhibitors, sitagliptin, saxagliptins. The gliptins is known for the DPP4 inhibitors. So nothing but DPP4 inhibition means you are increasing the incretin. So incretin will do insulin increase and glucagon decrease. And what are the side effects? Pancreatitis, nasopharyngitis. Remember, DPP4 are not good for the patients of the renal failure. But only that one drug can be given, that is linagliptin can be given for this patient. Next, GLP-1 receptor agonist. That means good binding. These all are present in the subcutaneous form only. Example, glutides. Okay, the glutide drugs are known for the GLP-1. Same incretin increase, glucose will be decreased, insulin will be increased for this patient. Nausea, weight loss, pancreatitis is the side effects, and best Ozempic drug that can be given for the semaglutide, even those who are suffering from the renal failure also. SGLT2 drugs, These are the very good renal glucose reabsorption, and they are going to excrete via glucose excretion. And common side effects: genital infection, vaginal infection, urinary tract infection, dehydration, and sometimes if more and more dehydration, that can cause the decay also. And the drug names which will be end with the glyphozones, okay, canagliflozin and empagliflozin. And this is best for the heart failure patient because more and more fluid will be going out. Next, amylin analogs, pra-amylatate, slow gastric emptying suppresses the glucagon. Nausea, hypoglycemia is common with this patient. Type 1, type 2 can be given because of the SQ form. Next, alpha glucosidase inhibitors. This will delay the intestinal carbohydrate absorption. Patients, that's why acarbose meglitolol, there will be flatulence, diarrhea will be seen in this patient. It should not be given for the patients those who are suffering from the inflammatory bowel disease, liver failure or the renal failure. Next, thiazolidinoids, which will be end with the glitazones. And the best drug about this one is it is completely renal safe. But weight gain is seen, so avoid in the heart failure patient. So this is going to act on the PPAR gamma enzyme. Okay, these are the best oral hypoglycemic drugs that we are discussing now. So another point also take note here. If there is a GIP and the GLP-1, that is a agonist. If it is the drug, new drug is the tirzepatide, that is a famously known as Monjaro. That is a drug. Next, moving on to the statins, guys. Here we are going to have the four different classes. First is the most commonly used statins, atorvastatin, rosuvastatin. And what is the mechanism of action? That is going to inhibit the HMG-CoA reductase, so that cholesterol synthesis is going to decrease. So LDL will decrease, HDL will be increased, right? But it is highly toxic to the liver and also going to cause the myopathy. That is the first factor that is going to see in the statins. So it is, should not be given in the pregnancy and children. Next, fibrates, fenofibrate, gamiprazole and gamifibrosin, and it activate the PPAR gamma. So by that it is going to increase the triglycerides and also HDL, right? Triglyceride clearance, it is going to be caused by the fibrates, but it is associated with the myopathy and gallstones. Next, bile acid analogs, okay, like cholesteria, myamine and cholesterol and choleselvin. So whichever the drugs which will be the chole, that is going to be the bile acid binding resins or the analogs. Okay, what they are going to do, they are going to increase the conversion of the cholesterol to the bile acid, so that LDL will be decreased from the body. How? Because they are going to interrupt the enterohepatic circulation. Next, what is the benefits of this one? There is a decreased LDL, and whatever the fats, this is going to cause the GI upset because enterohepatic circulation is interrupted. Next, it is only drug that is safe in the pregnancy and the kids because it is only acting on the enterohepatic circulation. Next, niacin, commonly used for the patients of the those who are having the severe cholesterol. Okay, this will decrease the LDL and increase the HDL with the hormone sensitive lipase inhibition. Next, the side effects are flushing, hyperuricemia, hyperglycemia, and hepatotoxicity. And last one, monoclonal antibodies like evolocumab. This is due to PCSK9 inhibitor. Okay, so that LDL receptors is going to recycle and LDL will be decreased. So severe muscle reactions and near the site reactions of the injection, neurocognitive effects which is rarely seen. These are the statin classification. Next, moving on to the antiarrhythmics. In the antiarrhythmics, there are the four classes, guys. Okay, so the first class is sodium channels, second class beta blockers, third is going to be the potassium, and fourth is the calcium. Okay, so the first sodium, how can you remember? So Sonali Bindre, Priyanka Chopra. Okay, so first S1 1A, this is going to block the sodium and also potassium. Okay, both are going to be blocked. Okay, next, second one is going to be sodium and potassium is open. Okay, here the potassium is open, sodium is still closed. Next, here sodium is blocked and potassium is regardless. What are the example? Quinidine, prokinamide, disparidine and dispyramide, lidocaine, mexiletine and flecainide and propafenone. Okay, what are the mechanism of action? For the 1A drugs, it is going to increase the action potential, further increase the QT prolongation. And 1B, it is going to block the NA, but tissue is open, right? The potassium is open here. So there is a decreased AP duration. 1C strong Na block will be seen in this patient. In the 1C, these drugs are pro-arrhythmic drugs. So they can increase the arrhythmia also. Next, what are the side effects of the 1A drugs? It can cause the QT prolongation, torsades, depointers. Next, synchronism associated with the quinidine. Next, IB drugs, mostly confusion, tremors, seizures, and depression will be seen. And lignocaine, we all know that it can also cause the malignant hyperthermia. Next, beta blockers, metoprolol, atenolol, propranolol, and esmolol. It will decrease the SA and AV node activity, so further decrease the CA currents in the action potential, right? Next, it will increase the PR interval. Bradycardia, AV block, bronchospasm, hypoglycemia will be seen in this patient. Next, class 3, potassium channel blockers. So, best example, amiodarone, ibutylide, and torsades depointers will be seen with the most commonly this drug. And the best drug among all, amiodarone is going to be the best drug. Next, class 4, calcium channel blockers. It is going to have the verapamil, diltiazem. Again, it is going to increase the PR interval. Those who are suffering from the patient's asthma, we can give the verapamil for the PSVT, right? Constipation, bradycardia, AV block, these kind of simple symptoms will be seen in this patient. Okay. Next, one thing that you have to remember here, that is the amiodarone effects. What are the amiodarone side effects that you have to take note here? So first, let's see. Amiodarone is a well accepted anti-arrhythmic drug, guys. So it is going to cause the some of the main side effects. Okay. First, amiodarone. This iode which will be affected in the thyroid. Okay. Thyroid dysfunction will be seen. This patient, especially hypo, then the hyperthyroidism will be seen in this patient. Next, there will be rash, especially photosensitivity. Rash will be seen. So that is why it is also known as a blue man syndrome. Next, neuropathy will be seen. Okay. Neuropathy will be seen, and pulmonary fibrosis will be seen. It will also cause the LFT dearrangements. So that means liver toxicity is also seen in this. Next, corneal deposits will be seen. So all these will be associated with the amiodarone. But amiodarone is a very well aspected because it is having only the one thing, the decreased QT interval. Okay, decreased QT interval. The side effect which is associated with the potassium channel blockers, but it is very less likely. Okay, ibutylide which is going to have the more, but amiodarone is going to have the less type. Next, anti-glaucoma drugs, the classification. Prostaglandin drugs like latinoprost, bimetoprost, it is going to increase the uveoscleral circulation. And what are the side effects? Conjunctival hyperemia, iris pigmentation, ileus growth, cystoid macular edema, and uveitis. Next, beta blockers like timolol, and it will decrease the aqueous humor production. Side effects: bradycardia, blepharoconjunctivitis, blockage of the nasolacrimal duct, and corneal anesthesia. Next, alpha drugs, brimonidine, apraclonidine. First, remember about these two drugs is going to cross the blood-brain barrier. If they cross the blood-brain barrier, they are going to cross the drowsiness, depression, apnea. So that's why it is not given in the children's especially. And other than that, the eyelid retraction, follicular allergic conjunctivitis also seen. And alpha drugs is going to increase the trabecular flow, decrease the aqueous humor. Next, carbonic anhydrase. First, only oral drug that going to give an acetazolamide, decrease the aqueous humor production. And paresthesia, GI upset, metabolic acidosis, sulfa allergy will be seen. Next, pilocarpine is going to be the myotic, increase the trabecular meshwork outflow. Meiosis, broache, and retinal detachment is seen. And last one, lyric, very rarely used, netrosudil Rho kinase inhibitors, increase the trabecular flow and decrease the episcleral pressure. Hyperemia and corneal verticillata will be seen in the side effect. Okay, next coming to the milestones, very important, commonly asked in the pediatrics. First, gross motor, it is going to have the cephalocaudal pathway. For example, neck at the age of 3 months, 6 months sit with support in the tripod position, 8 months sit without support, 10 months stand with support, 12 months without support. Okay, by 15 months walk without support, 18 months running will be seen. And by the 3 years, 3 for 3, 3 for tricycle. Okay, and another one, 4 years the patient will be climbing upstairs and downstairs hops, that is also seen in this patient. Okay, Next, coming to the fine motor skills. So first 4 months bidextrous grab, 6 months unidextrous grabs only ulnar, and 8 months unidextrous at the radial site. Next 9 and 10 months is going to be for the pincer grasp. 12 months by that time mature grasp will be seen in this patient. Next, another features like 18 months patient is going to have the making the tower with the 3 cubes. 2 years, two words like two lines will be said by line, two ends will be drawn. 3 years circle and 4 years cross. Okay, four ends. 5 years, remember it is going to be triangle, and 6 years is going to be diamond. Next language, 3 years, sorry, 3 months cuckoo, and 6 months monosyllables, 9 months bisyllables, 1 year 1 to 2 words, 18 months 8 to 10 words. 2 years, one sentence at least. 3 years, 3 words. Okay, name, age, gender. 4 years, he can tell the story and rhymes. Social milestones, 2 years, sorry, again, 2 months social smile, 3 months mother regard, 6 months stranger anxiety, 9 months waves bye bye and peekaboo. 1 year patient is going to play the simple ball game. 2.5 to 3 years parallel play, and 4 years group play is same. These milestones can be integrated and asked towards. Again, revise again and again, read one more time. Next, moving on to the malnutrition. So here are the two pictures that we have seen here, guys. The classical conditions, right? The marasmus and the kwashiorkor. So first, what are the features that you have to remember from these two important factors, right? Marasmus and the kwashiorkor. So the kwashiorkor, so first, let's understand kwashiorkor. So kwashiorkor is going to associate with the protein deficiency. Okay, they are associated with the protein deficiency, and it is seen in the children. Okay, most commonly in the children, but edema is present. Okay, so the pitting edema is present in this patient. So the fat which will be preserved, fat will be preserved for this patient, and liver is enlarged. Liver is also going to be enlarged in this patient, right? And poor appetite. Okay, the patient will be having the poor appetite and decreased lethargy. Okay, lethargy will be also seen in this patient. And coming back to the marasmus patient, and how the marasmus patient is seen, guys. This patient is severe muscle wasting, so not just the protein. So this patient will be having the calorie deficiency. Okay, this patient is also having the calorie deficiency. So this patient usually no edema, right? Already you can see no edema. This is also so known as a muscle wasting and baggy pant appearances. Baggy pant appearances. The patient will be irritable. Okay, irritable. Patient also no fatty liver, no fatty liver, no fat also. Okay, no fat itself absent in this patient. And voracious appetite. Okay, very eager to eat. Voracious appetite will be seen in this patient, which is more severe, guys. Okay, kwashiorkor is the more severe condition than the marasmus. And for this, we have to have the WHO criteria. What does the WHO criteria will tell for the malnutrition patient? Especially the weight for height. Okay, the weight for height, it should be less than -3 standard deviation. And the patient will be having the edema. Okay, edema should be also present, and mid upper arm circumference should be 11.5 mm. That should 11 point centimeters. 11.5 centimeters should be seen. Okay, any one of the following is seen, then that the patient is considered as a severe acute malnutrition condition. First, next, moving on to the neonatal resuscitation. In the neonatal resuscitation, whenever you see that the baby is born, you have to check for the tongue, tone, and cry. If any of this is absent, then you have to patient warm up the baby and check for the secretions, clear the secretions, and dry and stimulate. Especially in the sole, you have to dry and stimulate the baby. And after that, check the baby's breathing. So if the baby is heart rate is less than 100 minutes per breath, then you have to do start the immediately positive pressure ventilation, and this has to done in the first 1 minute of the golden time only. Okay, and try for the 15 seconds. If it is still less than 100, then you have to start the chest compressions, and other modalities like ET tube should be connected for this patient. And if it is going again downwards, if the patient is less than 60 minutes, 60 beats per minute, then you have to start the patient with the epinephrine should be given for this patient. Okay, this is how we are going to follow the protocol, right? First, again, come back to here. First, you have to check the patient thumb, okay, tone, that should be checked. If it is not observing, then dry and stimulate. If it is still less, if the patient heart rate is less than 100 beats per minute, then you have to start the positive pressure ventilation for the 15 seconds. If it is not coming, then start the chest compressions. Okay, start the chest compressions and then check if the heart rate is less than 60 beats per minute. Then you have to start the patient on the epinephrine. Okay, epinephrine should be considered and also intubation is given. Right, this is the protocol that you have to follow, and these everything it should be done in the within the 1 minute immediately. This is the pattern that we are going to follow for the neonatal resuscitation. Remember, guys. Next, IMNC guidelines, which is very important. We are going to see the two different diseases here. One is the diarrhea and other one is the pneumonia. Okay, so first let's see the differences of the pneumonia. Okay, so for the pneumonia, recently the guidelines has been considered as very important, guys. First, for the pink category, it is severe pneumonia. Okay, this is severe pneumonia. So these patient which will be presented with the danger signs, okay, such as vomiting, malnutrition, all this will be seen in this condition. Along with the danger signs, there will be fast breathing, okay, fast breathing plus and minus chest indrawing, okay, chest indrawing, which will be also seen in this patient. What is the treatment protocol? The treatment protocol, you have to give the first IV dose. IV dose is given and refer the higher center immediately. Next condition, this is the pneumonia. This is the pneumonia, and in the pneumonia, you are going to see the fast breathing. Fast breathing is seen in this condition, and treatment for this patient is given the oral antibiotics. Oral antibiotics is given and follow up for the danger signs, and immediately after that 3 days follow up is given for this patient. Next, last one, this is the no pneumonia at all. The patient is no pneumonia at all, just the patient is suffering from the cough or cold, that is seen here. Next treatment is supportive. Accordingly, if there is a fever, paracetamol. If there is a dehydration, then the ORS and the breastfeeding. Next, moving on to the diarrhea condition. So severe dehydration. Severe dehydration signs, you all know that the first sign is patient lethargic, right? The patient is lethargic, and it can be sometimes patient will be associated with the sunken eyeballs, dry mouth or dry tongue, we can say, and patient urinary output is decreased. Okay, and this patient will be given immediately IV fluids, okay, using the holiday cigar method. And also along with that, ORS plus antibiotics should be started. Next, those who are suffering from the moderate, okay, moderate, or we can say this as a some dehydration. This patient is irritable, and thirsty. Irritable and thirsty is seen in this patient, and also restlessness. Okay, restlessness. For this patient, we are going to give the rehydration solution. Okay, rehydration solution along with that ORS per episode. Okay, ORS per episode that we are going to give. Rehydration solution is 75 ml per kg. Okay, along with that supportive treatment is also given, and complete no dehydration, and no dehydration, the patient will be only the per episodes lbm that will be seen, and for this patient the treatment will be supportive breastfeeding, rice water stools, okay, ORS should be given. So this is the IMNC guideline and differences. Next, moving on to the types of cataracts. So first here, the snowflake cataract, which will be seen in the diabetes type 1 mellitus. Cortical site is the first. And senile cataracts, they are the different. First one is a nuclear cataracts, Morgagian cataract. Here you can see This is seen in the cortical, and this is the intumescent, completely fluid-like structure. Next here, the traumatic cataract, which is known as a rosette cataract. Posterior subscapular is a site. Next, metabolic cataract, sunflower cataract, also known as Wilson's disease. Next, Christmas tree cataract, seen in the myotonic dystrophy. Oil drop cataract, seen in the galactosemia, and most commonly, this is the reversible. Okay, if it is left treated early, it is a reversible. Next, moving on to the squint. In the squint, you have to take note about the important points of the extraocular muscles. So what are the extraocular muscles and what are their innervation? Okay, only the simple mnemonic that most of the all, we can say all muscles that are involved here is going to be supplied by, okay, all extraocular muscles are supplied by third cranial nerve except LR6 SO4. Okay, so lateral rectus is supplied by the sixth cranial nerve and superior oblique is supplied by the fourth cranial nerve. Okay, that is the first thing that you have to remember. And here you can see this is the picture: superior rectus, inferior oblique, and inferior oblique superior rectus. So third cranial nerve here LR6, sixth cranial nerve, and SO4, fourth cranial nerve. So this is the medial, this is the lateral, and here you can see superior oblique, inferior rectus. So rectus muscles are always straight. So rectus for upward, inferior rectus for the downward. Superior oblique, it has to be actually upward, but it is obliques are seen diagonally, right? So oblique, the superior oblique is for the downward, inferior oblique is for the upward. For the medial towards the nasal is medial rectus. For the lateral temporal side, it is going to be LR6. This is how the vision will be seen in the patient. Next, coming to the squint, cranial nerve palsy. How can you understand what are the muscles? So cranial nerve, third cranial nerve palsy is going to involve all muscles, right? So it will involve medial, inferior, superior recti muscle, and that is going to cause inferior oblique muscle, levator palpebral muscle, and also ciliary constrictor pupil muscles also, that is going to have the palsy. So these patients will have the vertical diplopia. Okay, multi-directional. There is a diplopia is seen in this patient, and ptosis is seen because here eyelid is also involved. So the ptosis will also see in this patient. So here you can see pupillary dilation and down and outward, which will be seen because LR6 and SO4 is not involved. That's why the down and out will be seen in this patient. That is cranial nerve palsy 3. Next, cranial nerve palsy 4, which will be only involving the superior oblique. So the rotational diplopia will be seen. So the patient will be looking downward and towards the nose. Next, abducens nerve, lateral rectus is only inward. The patient will be have the horizontal diplopia, and always remember the gaze will be going towards the affected side. Okay, the gaze will be going towards the affected side. This is seen in the squint, and this is the nerve innervation. Okay, next, coming back to the vitamin deficiency. Okay, what we discussed a while ago, the vitamin deficiency, the most commonly seen in this patient. What are the condition, guys? Bite or spot, keratomalacia, and these condition is seen. But there is a classification that you have to take note. Okay, first, these patient, those who are suffering from the vitamin A deficiency, what is the most common cause? It's the nutritional. Okay, nutritional is the most common type, and this is the common cause for the blindness in the children. Okay, this is seen as a baldness in the children. What are these spots, guys? These spots are known as a bitoid spots, and if you left untreated, this is going to cause the ulceration. And these are the follicular dermatitis, also known as a pyrenoderma, right? But the staging that you have to remember, xerophthalmia staging, that can be asked in the examination. What is this xerophthalmia stages that you have to remember? According to the xerophthalmia classification, the patient, those who are suffering from this, what is the first symptom? Okay, the first symptom which will be night blindness. Okay, that is night blindness which will be accompanied. But the first sign is going to be bitoid. Bite spots are the first sign when we are going to see. What is the classification here? ZN is for the night blindness. Okay, ZN is for the night blindness, and Z1A is due to conjunctal. Okay, conjunctival xerosis. Okay, Z1B, B for B for Bitots. Z2, sorry, X2, that is corneal xerosis, means dryness which will be seen. Okay, next X3A, keratomalacia. Already the ulceration is started in this patient. Okay, less than one third. Okay, next this is keratomalacia, more than one third. Okay, XS, which will be corneal scar. Okay, complete scar, irreversible scar is already. XF is going to involve the fundus. Okay, this is the staging for the patients, those who are suffering from the xerophthalmia. And next, coming to the dosage, guys. What is the treatment? Vitamin A is given. Okay, vitamin A is given on the day 1 and again on the day 14. This is how we are going to treat. Next, prevention. For the prevention, as I said, this is going to be the blindness in the children. So to prevent that, at the age of 9 months, we are going to start the vitamin A in the form of drops. So what is the dosage? If the patient is less than 6 months, 50K international units. If the patient is 6 months to 1 year, 1 lakh units. 1 lakh international units. If the patient is more than 1 year to 2 years, then 2 lakh international units. Okay, that is how we are going to give. Okay, up to 5 years of age, we can give the 2 lakhs international units, but it is started around the 9 months, because if it is given excess, it can cause the toxicity. Okay, hypervitaminosis especially will be presented as a pseudomembrane. Okay, pseudocerebral tumor. Sorry, this is pseudocerebral tumor that will be seen. Okay, and increased cranial tension will be also seen. That is a vitamin A deficiency. Next, coming back to the biosafety. So in the biosafety, guys, again you have to remember this very direct bits. It can be asked in your examination, right? Commonly, we are going to see this question in the examination. Very often asked, what is the dustbin? What is the discarded material that we are going to end up here? Okay, these are the common questions. Okay, and understand that when you are going to hand in the yellow bin, in the yellow bin, what are the wastage that you are going to put? Commonly the wastage of the human, like placenta. If you see, placenta is discarded where? In the yellow only, right? So like that, you are going to discard the human waste. Okay, it is going to be the human waste. Along with the human waste, you can also weigh the cytotoxic. Okay, cytotoxic such as the drugs, wasted drugs, that can be also told. Next, petri dishes. Okay, microbiology petri dishes can be used. Next, feces. Okay, vomiting, and also clothes which will be damaged due to the body fluids. Okay, which will be attached to the fluids, that can be also thrown. An empty blood bag, and cotton, gauze, this will be also thrown in the yellow one. Next, coming to the red color, we are going to throw gloves, IV sets, bags, okay, such as police catheter, urinary bags, okay, this can be urinary bags, police catheters, IV sets, IV cannulas, and syringes, okay, syringes and catheters. Different types of the catheters is also thrown here. Next, blue color is going to be mostly glass, broken glass, or the discarded glass items. Next, metallics, okay, metallic implants, empty vials, okay, empty vials and empty ampoules, that is also discarded here. Next, in the white, mostly sharps, right? Fixed syringe, for example, fixed syringe, that is also thrown here. Next, blades, knives, okay, scalpel, this is on the white color. right? This is the biosafety that we are going to use. Next, food adulteration. So in the food adulteration, you have to take note important points. Here, this is condition is due to neurolathyrism. Neurolathyrism due to kesari dal. So in the kesari dal, what is the particular toxin is presented? That is BOAA. What is this BOA? Beta oxylyl aminoalanine that is present in this patient. Kesari dal, if you are taken, that is going to cause the neurolathyrism. It's nothing but it is going to cause the spastic paralysis. So what is the prevention? Vitamin C 500 mg is given for the prevention and ban the crop. Okay, that is the one way we can avoid this. Next, this is aflatoxins. Aflatoxins is most commonly going to cause the hepatocellular carcinoma. This maize, this groundnut is going to be adulterated, stored, and that will be going to cause the this aflatoxicosis. Hepatocellular carcinoma will be seen in this patient. So better store in the humidity and improve the storage techniques, that is important. Next, this condition is endemic ascites. Endemic ascites which will be associated with the Cotarella seeds. Okay, Cotarella seeds. So these Cotarella seeds which will be consisting of the pyrrolizidine. This toxin is going to cause the endemic ascites, like liver toxicity will be seen in this patient. Next, these are ergot alkaloids which will be increase the vascular ischemia. Why this vascular ischemia is seen, guys? This is going to be vasospastic. Okay, this is going to be vasospastic. This kind of rye, okay, bajra, that will be seen in the northern regions of the patient. Next, these are the junjunia seeds. Okay, this is going to cause the epidemic dropsy. Epidemic dropsy. Dropsy means they are going to cause the severe edema or the anasarca. A complete body will be involved. What is the toxin that is present here? Sanguinarine. Okay, sanguinarine that will be present in this patient, right? This is some of the toxins and associated conditions and toxin names. Next topic we are going to discuss here is a demography. So in the demography, there are the 5 different phases, guys. One is the high stationary, early expanding, late expanding, and the low stationary. So let's see what are the different changes that will happen here. So in the stage 1, it is going to be high stationary, right? So here the birth rate is going to increase and death rate is going to increase. Okay, both are going to maintain the steady rate. Next, second stage is going to be early expansion. Okay, this is mostly on the early expansion. So the birth rate is going to keep increasing, but death rate is going to start. So there is a maximum gap. Okay, there is a maximum that gap is seen here. Next, third stage is going to be the late expansion, and here the birth rate is going to decline and also death rate is also going to decline. And here the first time both show the decline. Okay, both are going to show the decline. Next, in the fourth stage, this is known as a low stationary. So here again more and more birth rate will be declined, and here slowly death rate is going to decline. So this is known as a low stable gap between the both population growth. Next, fifth type. This is the fifth stage. This is declining phase. Okay, in this declining, both will be declining, but at very slow. Okay, and this is going to be into the negative stage. Okay, almost all the developed countries, it's at this stage, and some of the developing countries is at in the late stage. Okay, this is how the demography that is maintained. Next, moving on to the bone metabolic disorders. Okay, in the bone metabolic disorders, you have to understand what is the difference between the osteoarthritis and what is the rheumatoid arthritis. Okay, first let's see, guys. Osteoarthritis, it is a degenerative condition. Okay, this is the degenerative condition, whereas those who are suffering from the rheumatoid arthritis is most commonly, this is due to autoimmune condition or seropositive condition. Okay, let's see some of the other changes that you have to understand. Osteoarthritis mostly age related, so more than 50 years. This is seen in the 30 to 40 years of age. Mostly males and females equally predilected, and here females are more affected. And most common joints that is involved here, carpals, okay, that is going to involve the carpals, pip joints and the dip joints. Here the most common is going to be metacarpal joints, okay, and joints that is involved here is the asymmetrical. Okay, randomly the joints can be involved in this patient. Here always symmetrical. In the rheumatoid arthritis patient, it is going to be always symmetrical, and it will be the patient is going to decrease the pain with rest, and here it is decrease the pain with work. Okay, the work will decrease the pain, here the rest will decrease the pain. Next, coming to the other important point, rheumatoid arthritis is going to be positive for the anti-CCP citrulated antibodies. Okay, and here no antibodies and no erythrocytes sedimentation rate or the CRP elevation. And here ESR plus also patient with the CRP which will be elevated. What is the drug of the choice for this patient? So here also we are going to give the NSAIDs, and here also drug of the choice is the NSAIDs. But as it is an autoimmune condition, we have to start this patient on the DMARDs. And for this patient, arthroplasty can be done. Arthroplasty can be done for the surgeon. Right. Next, what are the deformities on the X-ray you are going to see? This osteophyte formation, narrow joint ulcerations, that is a thickened capsule which will be seen in the osteoarthritis. Next, rheumatoid arthritis, same narrow, but there is an increased synovial fluid and pannus formation. Destructive erosions will be seen in the cartilage. So this is known as a deformity. This was known as a botanier deformity, and along with the botanier deformity, the patient will be also having the swan neck deformity. Okay, swan neck deformity and botanier deformity. And here in this patient, there will be Heberden nodes. Okay, Heberden nodes and Bochard nodes which will be seen in this patient. Next, moving here, this is the ankylosing spondylitis. Ankylosing spondylitis which will be seen with the what is the common HLA that is associated here, guys? HLA B27. Males are most commonly affected. 20s to 30s years of age will be affected for this patient. Common symptoms, the patient will be having the morning stiffness. Okay, morning stiffness. And again here also with the work, the pain will be decreased in this patient, right? And there will be the fusion ilitis that will be causing the bamboo spine on the X-ray or the dagger sign you are going to see. And over the time, this will be causing the sacroiliitis. Sacroiliitis, the stiffness will be completed. Next test, that is known as a Scober test. In the Scober test, you are going to ask the patient to flex forward, and this flex forwardness will be decreased in this patient. Drug of the choice for this patient is the NSAIDs. And extra articular, the most common is the uveitis seen in this patient. Whereas rheumatoid arthritis extra articular, the most common is the rheumatoid nodules. The rheumatoid nodules will be seen in this patient. Next, osteoporosis. This is the condition, osteoporosis. What happens in the patients of the osteoporosis, guys? Here you can see this is due to destruction of the minerals. Okay, when there is a decreased mineralization, this is how the bone will be seen in this patient. Especially most common post-menopausal patients with the most post-menopausal, and also females more than the males, and the patients those who are having the history of the smoking, alcohol, okay, those who are taking the steroids, anticoagulants drug such as the heparin, common drug, and also those who are taking the cocaine or the toxins. This kind of the people will be having the osteoporosis. What is the gold standard test? DEXA scan should be done for this patient. If it is less than 2.5, that is positive for this patient. Next drug of the choice for this patient is the bisphosphonates. Okay, this bisphosphonates is given, but side effects that is associated with will be atypical fractures, right? Why this atypical fractures? Because this mechanism of action is osteoclast. Okay, osteoclast resorption will be seen. Over the time, this osteoclast will cause the atypical fracture. Other than that, it can also cause the severe gastritis. This is also one of the side effects related to the osteoporosis. Next, moving on to the lung tumors. These are the benign tumors. Okay, these are the benign tumors. Before that, you have to know what is the most common malignant. Okay, the most common malignants, that is metastasis. Okay, metastasis will be the same, especially coming from the prostate and breast. Okay, other than that, the most common malignant type is going to be, this is the overall. Okay, but what is the most malignant type? Then it is multiple myeloma. Multiple myeloma. Okay, this is overall, guys. Next, coming to the benign tumors, here you can see exostosis osteochondroma, which will be involving the metaphysis, persistence of the bony outgrowth. This is the most common benign tumor, and if it is transformed to the malignancy, it will cause the chondrosarcoma. Next, osteoma, here the nidus formation will be seen, and the radiolucent nidus, which will be showing as a sclerosis. And the classic presentation, the patient will be having the night pain relieved by the NSAIDs. Next, enchondromas, which will be seen multiple chondromas associated with the Maffucci-Ollier disease, and this will cause the metaphyseal small bones. Most common bone tumor in the small bones and can cause the chondrosarcoma. Next, giant cell, which will be showing the show bubble or the eggshell classification in the epiphysis, and it has to be treated extensive curettage for this patient. Next, moving on to the malignancy types, osteosarcoma. This is going to cause a sunburst and the Codman's triangle. Here you can see sunburst or the Codman's triangle you are going to see. Most common primary malignant tumor and radio resistant tumor also. Ewing sarcoma, onion skin appearances associated with the 11 and 22 translocation and CD99 gene. Next, chondrosarcoma, rings and arcs calcification will be seen. Cartilage tumor resistant to the chemotherapy. Next, fibrous dysplasia, Shepherd's crook deformity, and developmental anomaly that is associated with the fibrous tissue. On the biopsy, Chinese letter will be seen. Multiple myeloma, lytic lesions, punched out lesions. Here you can see this punched out lesions will be seen. Most common malignant bone tumor, this condition. Okay, next, coming to the schizophrenia. In the schizophrenia, better you have to know about the all important points related to the antipsychotics, guys. Okay, so for the antipsychotics, the question can be expected in the examination, right? So we'll see the antipsychotic classification and important points related to that. Okay, first, the schizophrenia patients will be having the given the drugs that is known as a antipsychotics. Okay, these antipsychotics are two types. One is typical and other type is the atypical. Okay, first, these typical drugs which will be considered as a first generation. Here this is the second generation. Okay, so the first generation drugs which will be going to block the D2 blockers. Okay, dopamine D2 blockers, and here these drugs is going to block D2. Along with that, serotonin is also going to be blocked here. And when you are blocking the D2, extrapyramidal tracts will be aggravated, so the side effects will be more. Here, extrapyramidal symptoms will be decreased in this condition, right? Other than that, here there will be neurotoxicity, but here metabolic toxicity is more. Okay, metabolic toxicity is more in this patient. So what are those extrapyramidal symptoms? Let's see. Extrapyramidal symptoms can be most common dystonia. Okay, dystonia can be occur within minutes to hours after taking the drugs. So what is the antidote that you have to given? Benzexol. Benzexol is the drug of the choice to treat the dystonia. Next, akathisia. Okay, akathisia. This can be seen in the days. Okay, this can be seen in the days. The drug of the choice for this patient, propranolol, can be given as a drug of the choice to decrease the akathisia. Next, the patient will be having the tardive dyskinesia. Tardive dyskinesia can be chronic. Okay, it is chronic, and for this patient, you have to stop the typical drugs, stop the typical drugs, and start the patient on atypical. start the patient on atypical. Okay, and other drug that you can give for this patient is the valvaxin. Sorry, here you can see this drug is valbenazine. Okay, next other one is the Parkinsonism. Parkinsonism is also seen in this patient. Here also the drug of the choice is benzexol. Why this extra pyramidal symptoms is coming, guys? Because you are blocking the patients with the D2 blocker and hyperprolactinemia, which will be seen with the risperidone. Immediately you have to withdraw this drug. Okay, withdraw this drug. Next, coming to the typical drugs that will be associated with the metabolic symptoms. Okay, metabolic symptoms such as increased weight gain. Okay, that is seen with the clozapine and also olanzapine. Okay, but clozapine have its own specific side effects. So clozapine can cause the agranulocytosis. Agranulocytosis will be seen and seizures. Okay, dry mouth. Sorry, there will be siluria. Okay, increased siluria will be seen in this patient, right? This is seen in the clozapine. And what about the zero? Okay, there will be zero metabolic effects. Zero metabolic effects. Z for zero, Z for Zipra. Okay, the drug that will be Zipraprozole. Okay, this Zipraprozole, which will be ziprasidone, which will be associated, or also ariprazole, which will be zero metabolic effects that will be seen. Okay, next, those who are suffering from the resistant schizophrenia. For this patient, the drug of the choice is the clozapine that you have to give. This is the overview of the schizophrenia related the drugs and their side effects. Next, depression. Depression also important points that you have to take note is the drugs only. First, SSRIs, okay, SNRIs and atypical drugs. Okay, atypical drugs. So first, let's see the SSRI. This is the mechanism of action. You are going to block the 5-HT that is going to be blocked. Okay. So what happened? The usually these patients will be associated with the some of the side effects, such as the most important one is the premature ejaculation. Okay. The patient will be having the delayed ejaculation. So this is going to have the delayed ejaculation. If it is delayed, most commonly D for dapoxetine. Okay, dapoxetine drugs which will be associated with the delayed ejaculation. And also there will be risk of serotonin syndrome, which will be also seen in this patients. Next, SNRIs. This SNRIs is going to increase the patients with the 5-HT and also norepinephrine. If this norepinephrine is increased, the patient will be associated with the hypertension crisis. That is also seen here. Next, atypical drugs such as TCS. Okay, these TCS which will be causing the toxicity. Okay, to decrease this toxicity, you have to give the antidote that is HCO3 or the bicarbonate should be given for the patient to treat. Okay, and this TCA which will be associated with the hypertension crisis. Okay, another point. Next, the atypical drugs such as uses bupropion. Okay, use it for the smoking cessation, right? Smoking cessation you are going to use, right? This is also one of the point that you have to remember. And cardiac toxicity will be seen with the tricycline disorders. Next, in the depression, you have to take note about the lithium, guys. So lithium will be having the specific side effects. What are those? Nausea, vomiting. Okay, along with that diarrhea. These are the early symptoms, but they are going to have the tremors. These can be start as a fine, but over the time it can be become the course. Okay, and there will be a diabetic insipidus in the nephrogenic and dysarthria, thyroid dysfunction, which will be seen. And if the mother is taking abstinence anomaly, right, this all will be seen with the patient. And even it can cause the renal failure, which needed the hemodialysis. Those are the patients suffering from the lithium toxicity. Next, moving on to the forensic medicine thanatology. Okay, in the thanatology, you have to take note. What is the thanatology, guys? It just study of death. Okay, it is known to the study of death. So here you are going to see the alvar mortis. What is meant by the alvar mortis? Cooling of body. Okay, this is seen as a cooling of the body. So when the algar mortis is going to see, okay, algar mortis is going to see, it is going to see the calorosity of the algar mortis, especially 0.4 degrees to Celsius, 0.7 degrees Celsius per hour. It is going to start the cooling of the body. Okay, next, this is known as a hypostasis. This is known as a hypostasis or the post-mortem staining. Okay, and also known as a suggelation. So early it is going to start by the 30 minutes. Okay, and it will last for the 8 to 10 hours. But when it is fixed, it will be fixed by the 6 hours. So this is known as a putrefaction. Okay, this is known as a putrefaction. What is mean by the putrefaction, guys? So there is a gas production. There is a gas production, and here you can see complete color change. Complete color change will be seen in this patient. Next, other one, rigor mortis. Okay, rigor mortis, there is a decreased ATP. The patient is going to become the stiffening. Okay, due to the ATP depletion. Okay, muscle stiffening. So it is going to follow the Nystag's rule. Okay, Nystag's rule from the part. For example, it will start from the eyelid and then it will end from the lower limb. This is known as a Nystag's rule. And how it is going to start, guys? It is going to start from the 60 minutes of the body and it will follow the rule of 12. Okay, rigor mortis is going to follow the rule of 12. What is the rule of 12? It is going to start exactly 12 hours by death, and after that, the death after 12 hours P, and after this, so 12, 24, after 36 hours, it is going to disappear. Okay, this is the rule that you are going to see with the rigor mortis. Okay, next, what is this condition, guys? This condition is known as a cadaveric spasm. Cadaveric spasm, seen especially in the patients of drowning condition, right? Drowning condition, and this is known as a ante-mortem finding. Okay, this is known as a ante-mortem finding. No relaxation that is seen. Next, here you can see this is the mummification. This is known as a mummification and seen usually around 3 months to 1 year patient. This will take mummification. Completely the patient is dry, dehydrated, okay, and shrunken, which will be seen, right? And completely odorless. Next here, this is the condition of the marbling. Yeah, this is the condition of marbling. This is due to sulfur hemoglobin. Okay, sulfur hemoglobin, which will be showing the green vessels. The visible vascularity is due to sulfur hemoglobin. Sets from 36 to 72 hours of the death. Next, here you can see this is the adipocere. Okay, adipocere, or which will be also known as a saponification, and this is going to have the very bad smell. What is the smell known as ammonical smell? Ammonical smell will be seen in this patient because not just by the fat, also the fat is mixed with the bacteria. That is why it is going to have this smell. Next, moving on to the toxicology, guys. In the toxicology, you have to take note of the antidotes. Okay, antidotes is very commonly asked in the examination. What is the antidote for the metals? Let's see, arsenic. So here you are going to give the British. Okay, this ball can be given, or also damsa can be given for this fish. Next, copper, damsa, copper also we are going to use the damsa. Okay, next, iron, desferoxamine. Okay, next, lead, EDTA is given. Next, cadmium, DAMSA. Okay, mercury is also DAMSA. Okay, carbon monoxide, oxygen, 100% oxygen should be given for this patient. Okay, carbon monoxide. Cyanide. Cyanide patient, you are going to give the nitrate. Okay, along with that, B12 is given for this patient. Next, cocaine, you are going to give the amyl nitrate, right? Next, methanol. So the patient, those who are taking the methanol, we are going to give the omeprazole. Next, those who are taking the benzodiazepine, toxicity. For this patient, we are going to give the flumazenil. Okay. For the patient, those who are taking the paracetamol, NAC and acetylcysteine should be given for this patient. Next, opioids. Opioids patient, naloxone is given. Okay, naloxone is given for this patient. And OP poisoning, atropine. You are going to give the atropine. Next, paralodoxine. Low toxin is given for this patient. Carbamate poisoning for the patient, those who are suffering from the carbamate, just atropine is given for this patient. Next, datura poisoning. For this patient also, we are going to give the atropine. What if it is a atropine poisoning? For the atropine poisoning, we are going to give the physostigmine. Okay, physostigmine is given for this patient, right? These are the important points that you have to take note. What are the antidotes? If it is a beta blockers, if it is a beta blockers, you are going to give the glucagon. Okay, these are the antidotes you have to remember, guys. Next, pneumoconiosis. What are the important one? The most common one will be the silicosis. Okay, this is the most common associated with the silica dust. Okay, next, bisonosis. Bisonosis is associated with the cotton. Okay, cotton industry. This is associated with the bisonosis. Next, asbestosis. Okay, asbestosis is most commonly associated with the shipyards. Okay, shipyard people, it is going to be associated. But asbestosis, another important points that you have to know about is it is have the risk of malignancy. Okay, most common it is going to cause the adenocarcinoma. But if they ask the most specific, it can cause the bronchogenic carcinoma. Bronchogenic carcinoma. Okay, and most common, this is the very rarely asked, but another one is the mesothelioma. Mesothelioma. Next, we also have the anthracosis. Okay, cement industries. Cement industries, anthracosis, there will be ferruginous bodies. Ferruginous bodies you will see on the histopathology. Okay. Next, bagosis. Bagosis will be seen in the sugarcane. Okay, sugarcane patients. And silica patients, TB risk is zero and also cancer risk is zero for this patient. Okay, only patient with the glass and shipyard industry, asbestosis patient will be having that condition. Next, lung tumors that we are going to discuss here. Lung tumors, very commonly asked question, guys, and most of the questions will be directly asked only. And remember that this is the exception. Okay, you don't have to remember this. This is the exception. You are going to learn squamous, small cell carcinoma, adenocarcinoma only. Okay, only these types that will be differentiating in the examination. Okay, first, let's start with the squamous cell carcinoma, most commonly seen in the males rather than the females. And overall, all the lung cancers, this is the most common. It is going to involve the central part of the lungs. Okay, and this is associated with the smoking. This is associated with the smoking patients and P53 gene that is mutated. P53 gene is mutated in this patient. For the stains, you are going to use the P63 and P40 and cytokeratin. And paraneoplastic syndrome, especially increased calcium, hypercalcemia will be seen. On the histopathology, you are going to see the keratin perils. Okay, keratin perils will be seen like this. Keratin perils will be seen in this patient. Next, small cell lung carcinoma. Again, here also males most commonly involved, smokers, highly metastatic condition, and this patient will be having the genes of elmic gene, and this patient will be associated. What are the stains that we can use for this patient is the chromogranin, and also synaptophysin, that is given for this patient. It's very severe condition and poor prognosis is seen. And on the histopathology, you are going to see the Azupardi effect. You are going to see the Azupardi effect for this patient. Okay, and small cell lung carcinoma, this Azupardi, like thickness of this going to be seen in this patient. Next, paraneoplastic syndrome. You are going to see the SIADH and also Lambert-Eaton syndrome, and Cushing will be present in this patient. Next, adenocarcinoma. Females are most commonly involved in the males, and peripheral tissues which will be involved. ALK and EGF. Okay, EGFR gene are involved in this patient. Okay, paraneoplastic syndrome will be calcium will be increased. Along with that, there will be thrombophlebitis, migratory thrombophlebitis. And what are the stains that is formed here? TTPF positive and also napsin A, that will be positive. And you are going to see the lipidic pattern on the histopathology that will be seen. And large cell carcinoma is an exception. If you don't see any features, then that is a large cell carcinoma. Right? Next, facial palsy. What is the difference, guys? This is the lower motor neuron. This is the upper motor neuron. Okay. First, lower motor neuron directly going to affected on the same side. So anywhere along with the nerve that you are going to affected. Ipsilateral side, right? That is affected. So both will be involved. Forehead is also involved in this patient. Next, coming to the upper motor neuron palsy. Here, this is going to be the lesion is on the this side, but the affected will be here. Forehead is paired here. Okay, forehead is not involved, and if the lesion is this side, you are affected on the opposite side. That is known as a contralateral side. Heteroma, most commonly asked, epidural and the subdural. Epidural is due to middle meningeal artery, subdural is due to bridging veins. In the epidural, we are going to see the lucid interval that will be commonly seen. In the subdural, no lucid interval. It can be acute, it can be chronic, or it can be subacute also. And on the diagnostic NCCT, the biconvex shape and the idli shape that is seen in the EDH, and sickle S for S for subdural, that will be crescent shape seen on the patients of the subdural hematoma. For the both patient, craniotomy is the treatment of the choice. Next, SIH. Okay, SIH is due to rupture of the vessel. Okay, especially in the circle of Willis. And this patient, you are going to see this SIH in the basal cisterns. You are going to see this blood flow. And most commonly associated with the females, alcoholics, cocaine use, and those who are suffering from the polycystic kidney disease. And berry aneurysm, that is going to be ruptured in these places. Next topic we are going to discuss is the collagen. In the collagen, you have to remember the important points. What are the four types? Okay, there are the four types. What is the first type, which will be bone and tendons? Type 2, cartilage. Type 3, blood vessels. Type 4 is going to the basement membrane. Mnemonic scab. Okay, skin and also the bones, cartilage, and the basement arteries and basement membrane. These are the four types. The defects, the first type 1 collagen defect will be osteogenesis imperfecta. Type 2, and sorry, this is the type 3 defect, arteries, that is going to be the Ehlers-Danlos syndrome. Type 1 collagen defect, the patient will be having the bone fragility, multiple fractures, blue sclera, hearing loss. And Ehlers-Danlos, hyperelasticity, hyperextensive skin, and arterial organ rupture will be seen in this patient. Okay, next coming to the airway management. What is this maneuver that is performing here, guys? That maneuver is known as a head tilt. This is head tilt and chin lift. Okay, head tilt and chin lift for airway obstruction we are going to do. And this airway is known as a Goodell's airway placed in the mouth of the patients, those who are suffered from the trauma. Next, we all know this is Eustachian tube. Here you can see this is the Murphy's eye. This is the cuff. Why the cuff ET tube is important, guys? It will decrease the risk of aspiration. Okay, another point. Next, there are the different types of the airway management. So this is known as a nasal cannula. How much FiO2 it is going to carry? 0.24 to 45. Okay, how many liters of the oxygen? 6 liters of the oxygen per minute it is going to carry. Next, here it is simple mask. Okay, this is the simple O2 mask. So FiO2 will be for this one 0.44 to 0.60. 6 to 8 liters of the O2 per minute it is going to carry. And here you can see this is a non-rebreathing mask. This is non-rebreathing mask. In the non-rebreathing mask, the FiO2 will be 0.6 to 0.9. How many liters? 6 to 10 liters per minute of the oxygen will be carried. Next, other than that, this is going to be the highest. Okay, this is going to be highest Venturi mask. This is the Venturi mask, and here the FiO2 will be 0.2 to 0.6, but it can be more than 12 liters per minute of oxygen will be carried. Next, what is this one, guys? This is known as a laryngeal mask airway. Okay, this is the classical laryngeal mask airway, and this will be useful for the early to use and less neck bending is done. Okay, less neck bending will be done for this patient. Right, that is the laryngeal mask airway. Next, chemotoxicity. Just by this picture, you have to remember the C which will be seen with the kidney and also ear. So carboplatin and the cisplatin will be causing the ototoxicity and nephrotoxicity. When Christine, here you can see these are the limbs, and V for the peripheral neuropathy. Bleomycin and busfilone which will be causing the pulmonary fibrosis, and transimab doxorubicin which will be causing the cardiac toxicity. Cyclophosphamide, hemorrhagic cystitis, methotrexate, 5-fluorouracil and 6-MB which will be causing the myelosuppression. Okay, this chemo drug which will be toxicity is also asked commonly in the examination. Next, coming to the mycology. So common topics mycology, which microbiology in this, the mycology topics will be also asked in the examination. What are the important points that you have to remember, guys? First, here you can see the microsporum. The microsporum which will be involving skin, right, and also hair diseases. Trichophodon, tri means all. Skin, it is going to involve hair and also nails. Here it is going to involve the skin, and along with that nails is involved in the epidermophyta. So coming to the structure, so this is the microsporum structure that is going to be looked like a spindle shaped, and here trichophyton which will be looked like a pencil shape, epidermophyton looks like a club shaped pattern. Next, another picture, here you can see this is the copper penny bodies. These are copper penny bodies which will be seen in which what we say which type of the disease or the organism, guys. This is seen in the chromoblastomycosis. You are going to see this one. Next, this is the asteroid. These are the asteroid and cigar shaped bodies seen in the sporotrichosis you are going to see. Next, nemocystis. This is the condition, pink ball appearance, pink ball appearances. This is seen in the patients of the pneumocystis. Okay, pneumocystis. So what is this green color stain, guys? This stain is known as a gory methanoid stain. Okay, stain that is commonly used for this patient. Next, coming to the here the picture that you can see differentiate which is the rhizopus, which is the aspergillus. So basically the conditions which will be associated with the aspergillus, which will be less than 90 degrees. It is going to look like a less than 90 degrees. Okay, so this is your rhizopus. This is the rhizopus. and this is the aspergillus. Okay, this is the aspergillus. So what happens, rhizopus will be having the more than 90 degrees and everything will be irregular. Okay, but aspergillus less than 90 degrees and regular. Okay, this whichever is we are going to see, this one, right? This is the regular type of the aspergillus you are going to see, and here more than 90 degrees irregular shape will be seen in this patient, right? Next, coming to the other important, for example, you have the capsule formation, right? Capsule formation and India ink. India ink used in which organism, guys? Cryptococcus, right? Cryptococcus, you are going to use this one. Next, eight shape. Okay, eight shape. This is seen in the especially of the blastomycosis. Okay, blastomycosis. You are going to see this condition. Okay, and Mickey Mouse. Okay, Mickey Mouse or the Captain Wheel. This is seen in the paracoccidomycosis. You are going to see this types. Next, last topic for this short series, seed classification, which will be used for the patients, those who are suffering from the claudication or the atherosclerosis in the lower limbs, right? This patient. Seed classification will explain us what is the classification for to decide the venous diseases. C1 is for the telangiectasia and C2 is for the varicose vein recurrent attacks. C3 edema, C4 is going to be pigmentation, lipodermatosclerosis, and the corona telangiectasia. And C5 healed ulcer, C6 is active venous ulcer or the recurrent active venous ulcer. Okay, next E for etiology, EC congenital, EP primary, ES secondary. Anatomy, superficial vessels, deep venous or the perforators. And pathophysiology, obstruction or the reflexes. Okay, these two are going to be important. Next, ABI value. Okay, ankle brachial, this index we are going to check. First, more than 1.3, this is the falsely high level suspected to be the calcification sclerosis. More than 9 is going to be the normal. 7.5 to 9 mild peripheral arterial disease. 0.5 to 7.5 moderate, and less than 5 is the severe condition of the peripheral arterial disease. Next, this is the Boyd's grading. This is condition is the Boyd's grading. Type 1, the patient will be having the pain with continued walking. Type 2 is going to be walks in the pain. Grade 3 is compelled to take the rest, and grade 4 the patient is having pain at rest. This classification is also very important. So those who are new to this channel, please do subscribe and share with your friends. And guys, please do revise this 50 topics and stay tuned for the top Sure Shot series 2 and Sure Shot series 3. Until then, all the best, guys. Happy preparation.